전달해야 and Salutogenesis Symposium. Thank you for joining us today. My name is Tony, and we will begin with session 1, followed by a short coffee break, and then session 2. We will now begin session 1, exercise in advanced and metastatic cancer, evidence to practice. It is my pleasure to introduce our session chairs, Dr. In-Jung Yang from Seoul National University, Pundong Hospital, and Dr. Min-Suk Oh from Department of Sport Industry Studies at Yonsei University. Please welcome our chairs with a round of applause. Chairs, the floor is yours.
Welcome to this session, and my name is In-Jung Yang. My specialty is cancer rehab, and I'm working at Seoul National University Pundong Hospital. It's my pleasure to serve you as a chair, and my co-chair is.
My name is Min-Suk Oh. Here at Yonsei University, I'm working as a research professor.
Yes. Today's program highlights the innovation and impact work in cancer rehab and survivorship science. And the title is Exercise in Advanced and Metastatic Cancer, Evidence to Practice. Thank you for being here. And I'm looking forward to stimulate insight discussion. And I'd like to introduce our speaker, Ann May. Yes. Our speaker is Professor Ann May from UMC Utrecht, an international leading expert in cancer survivorship and exercise oncology. And she had published over 50 scientific papers and led major European and Dutch cancer society-funded trials, including preferable study. And she also served as a WCRF expert committee and ASCO guideline committee. Please welcome Professor Ann, and the floor is yours.
Good morning. Thank you for being here so early on a Sunday. Thank you for the invitation, Justin. Thank you for everything you already did here this week. And thanks to you students for caring so well for us. I'm happy to open the session on advanced cancer with presenting to you the results of the preferable study. I always first would like to acknowledge all my co-workers, because this was really a common and international project with many people and not only my own work. So yesterday we already discussed about guidelines, and we also talked about that we already have international guidelines for exercise and cancer. And these are, I think, the two most well-known international guidelines, the ACSM guideline that focused on exercise during and after treatment, and the ASCO guideline where the effects of exercise during cancer treatment was summarized and recommendations were given. And since the preferable study was done during treatment, I will shortly show you the recommendation of the ASCO guideline. And after thorough literature review, the recommendations were that exercise during adjuvant cancer treatment leads to improvement in cardiorespiratory fitness, strength, fatigue, and other relevant patient-reported outcomes. So the recommendation was that oncology providers should recommend regular exercise, aerobic and resistance exercise during active treatment. For curative intent, there was one research gap identified, and that was that when we made this guideline, there were no studies or no big studies including patients with metastatic disease. And that is where the preferable effect study fits. So in this study, we investigated the effects of exercise in patients with metastatic breast cancer. In preferable effect, we included patients in 5 European countries and in 1 center in Australia, and patients who were adult, had a diagnosis of stage 4 breast cancer, and a life expectancy that was estimated to be 6 months or longer were eligible for the trial. Patients who were too fit or too physically active or had contraindications for exercise, like or unstable bone metastasis, were not allowed to participate. Here you can see the design of our study. So we first did our baseline measurements, and then we randomized patients in either the intervention or the control group. We repeated our measurements at 3, 6, and 9 months, and our primary endpoint was measured at 6 months. The control group received a general physical activity advice, and we also provided a Fitbit. The exercise group received aerobic resistance and balance training, and in the first 6 months, this was done twice per week, supervised, and in the last 3 months, we already changed one supervised session to unsupervised exercise to help patients to keep exercising after the trial. Here you can see a summary of our training. So we always started with balance training, then strength training, endurance training, and we finished with a cool down. And our exercise program was done by periodization. And here you can see a link. We put the whole exercise program with all materials, the testing materials, on our website. So if you want to download it, you can download it and apply it in your own practice. What we also did in this program, we did adaptations to the exercise program if needed, if patients had bone metastasis at certain locations, and also this scheme is in our exercise material. Here you can see our outcomes. We had a lot of outcomes. Primary endpoints were cancer-related, physical fatigue, and quality of life. And before we started the trial, we defined that our trial would be successful if either or both primary endpoints would be statistically significantly different between the exercise and the control group. We have only measured a number of secondary endpoints, and I will present to you a selection of this today. So at the end, we randomized over 350 patients in our trial. It was like almost 180 patients in both groups. Patients were on average 55 years. We had 1 man in each group, and over 50% received endocrine treatment when they started the trial. Also, the majority of patients had recurrent disease, were treated in first or second line, and had bone metastases. First, when we finished the trial, we looked into the adherence, because you can make a program, give it to patients, and think that it's the most optimal program, but if they don't do it or are not able to do it, then the effects you measure is not your program, but perhaps something less intensive. But what we saw, the median attendance was 77%, and reasons for not attending were either hospital visits or disease progression. But it was not that patients quit the training sessions or the trial because they did not like the exercises. What you can also see is that 18% of our patients discontinued the study within the first 6 months. And this was in 44% of the cases due to death. And in our sample size calculation, we anticipated a discontinuation of 20%. So these 18% were accommodated in the sample size calculation. Here you can see the median compliance to all the components of our exercise program. And we were very happy with this compliance, because you can see that for all components, this compliance was above 70%. And in the whole study, we had 2 serious adverse events, and these were 2 fractures. And both fractures were not related to the exercise program, and were related to the exercise program, but not related to the bone metastasis or the disease. So now I would like to start with showing you the results for physical fitness, because exercise intends to increase physical fitness. And with this study, we investigated whether an increase in fitness is also possible in patients during their treatment for metastatic breast cancer. We had several tests, so we did physical fitness, physical performance, and muscle strength testing. And here you can see the results for the fitness testing. I think that I cannot do that. Perhaps I can. Oh, it's here now. Yeah. So here you can see that the maximal short exercise capacity increased in the intervention group, and this increase was significantly different to the control group, where you can see that virtually nothing happened with their fitness. For the muscle strength, we also see that an improvement in muscle strength was possible during treatment for metastatic breast cancer. Very important, we also saw that the balance improved in the patients in the exercise group, and also functionally we saw an improvement in the 5-time sit-to-stand test. So taking this together, you can conclude that improving your fitness and your functioning during your treatment for metastatic breast cancer is possible. Now let's move to our primary endpoint, and as I explained, that is quality of life and fatigue. First, you can see the results for quality of life, and you can see from the figure that quality of life improved in the intervention group and was higher as compared to the control group during the whole course of the study. And for fatigue, and now you need to look at the lower line, because fatigue decreased during the intervention, and the decrease was higher in the exercise group as compared to the control group. And from that, we could conclude that the trial was successful. We also looked in some of the functional scales of the quality of life questionnaire, and you can see here that patients also report better physical functioning, but also better role and social functioning. And I think that is also a very important outcome, because it shows that patients could participate better in their social and work life while exercising. We didn't find effects for emotional fatigue, and also not for emotional functioning. So here you can see that the groups were comparable, and from that we conclude that if emotional functioning or fatigue is really an issue for patients, you should give them an additional program to work on that. Till yesterday, actually, we were not sure that, we thought that perhaps emotional fatigue was not increased. So that might be one of the reasons that we didn't see something. But just yesterday, a paper was published showing the important differences or the thresholds for the EOTC FA12, which we used. And from that, I learned that the emotional fatigue at baseline was increased. So patients, this is a relevant increase in emotional fatigue. So from that, we learned that there is an issue, but that was not tackled by our exercise program. So we should look into other options for the patients, like cognitive behavioral therapy, maybe. We also looked into symptoms patients have, and these are 2 symptoms which occur often in patients with metastatic disease. So the majority of our patient group had pain and dyspnea at start of our intervention. We also learned from a questionnaire we took in Europe from patients with metastatic breast cancer that patients do have concerns that pain might improve by exercising, and that would be a barrier for them to exercise. So it's important to also look into these symptoms. And here you can see that pain decreased in the exercise group. You can see my pointer? Yeah, okay. And that pain was significantly lower in the exercise group as compared to the control group. And also for dyspnea, we saw that at 6 months there was a significant decrease in dyspnea, and the effects were not significant here, but it was maintained also after 9 months. So we think this is an important finding also for clinicians, that if patients ask them, should I exercise, I have pain, I don't know whether this is something I should do, that this is very reassuring, that you can tell patients that exercise can even help them to manage their pain. Then another outcome we looked into, and this is quite a neglected outcome, it's sexual health of these women. When we look at the ACSM guideline, we looked into evidence for sexual health, but then we rated that in the red area, meaning that there were no studies that we could draw conclusions from. So here in Preferable, we also had a questionnaire on sexual health. And what we found was that patients in the intervention group reported better sexual functioning during the intervention. There was also less endocrine sexual symptoms in the group who received hormonal treatment. And here for sexual enjoyment, we do not see a significant effect. But if you look at the effect sizes, these are quite comparable to the effect sizes of the other items. So also this is, again, we think, a very important finding of the study. Now I will show you the results for body composition. We performed DEXA scans in 2 of our centers and looked into what the effects on lean body mass and on fat mass were. And what you can see here, that if we look at whole body lean mass, we see a significant difference at 3 months, but not at 6 months. For body fat, we do not see differences, and that is something that is often seen, because I think if you really want to lose fat, you should combine exercise with nutritional intervention to target body fat loss. But if we look into the muscles or the lean mass of the arms and the legs, and these were the regions the resistance training was targeting, you clearly see that lean mass improved in the exercise group in the absolute, but also if you calculate an index. So from these data, you can conclude that you can improve lean mass during treatment for metastatic breast cancer. So the last results I would like to show are on the immune function. We took blood draws at baseline 3 and 6 months. And I will show you just our first results, because we are currently writing the paper and there will be many more results. But what we found, these are the plasma proteins where we found significant differences between the exercise group and the control group at either 3 or 6 months or both. And what you can conclude from these findings is that we found lower levels of pro-inflammatory proteins, so IL-6, IL-8, CCL3, and TNF receptor SF9 were lower in the intervention group, and which supports that exercise causes a reduction in chronic inflammation. What we also found, we found higher levels of TWEAK and CASP8, and by that finding we hypothesized that pathways might be involved, might be activated that are involved in cell death. So we will look into more detail into these results, but I think it's also good to have some biological results supporting the fitness and questionnaire results. So from these findings, we can conclude that a supervised resistance and aerobic exercise intervention results in beneficial effects on fatigue, quality of life, fitness, sexual health, lean mass, immune function, and other clinically relevant outcomes. So if you have a study like this, then next thing would be implementation. And if exercise were a pill, I think this would be now the natural way. But since exercise isn't, we are still need to work on that and try to get exercise also implemented. But one condition is, and that is also said in this paper, that you also need to show cost effectiveness. So it's not only effects, but you add costs to the healthcare system, and that should be cost effective. So I will conclude with showing you the results of our cost effectiveness analysis. And what we did, we investigated whether the 9 months supervised exercise program was cost effective compared to the control group. And here you can see how a cost effectiveness analysis works. You have the difference you have in these two groups is that we add a 9 months program to the exercise to the people in the exercise group, which increases costs. Then you measure all healthcare costs and quality of life. And at the end, you have a ratio of costs and effects of your intervention, and by that you can calculate whether the intervention is cost effective and whether the extra costs are outweighed by the cost effectiveness ratio you calculated. And what we first did, we thought about, or we calculated the costs of the intervention. And we did this for two scenarios. First, one-on-one supervision and for one-on-4 supervision, because in our intervention, most patients did the exercise in a group. And what you can see here, it's in euros, I'm sorry for that, but you can see the difference is that the one-on-one supervision is like 1,600 euros, and if you do it in groups, it's cheaper, it's only 600 euros. And then we also looked into effects on quality of life with the ECO5D, and we saw that quality of life was higher in the intervention group as compared to the control group. And now if we look into the costs, so we calculated costs for several categories. We found, and here I did the calculation in one, so we found that for the GP visits, there was no difference between the two groups. But there were less costs for hospital care, and that was mostly because less visits to the emergency department. We found less costs for home care, less costs for informal care, and also there was less productivity loss in the exercise group compared to the control group, and this was especially less short-time sick leave days. So from that you can see that the costs on average were lower in the exercise group. And then the next step is to translate the effects on quality of life and on the costs in a cost effectiveness plane, and this is shown here. And what you want, the best thing is if all the points are in this quadrant, because that means that the effects are higher in the exercise group and the costs are lower. And if we calculate then a QALY, we see that there's always a willingness to pay threshold for a QALY. So in the Netherlands, for example, is the threshold 20,000 euros for supportive care intervention. For pharmaceutical intervention, this threshold is 80,000 euros. And if we calculate then the probability of cost effectiveness for one-on-one supervision, the probability of cost effectiveness is 65%. But if you calculate that for the one-on-4 supervision, then the probability is 91%. And this is a very high probability for cost effectiveness analysis. And so we can conclude that in the setting of metastatic breast cancer, an exercise intervention is cost effective. So to finish the presentation, I would like to finish with a quote of one of our participants. It's Ineke. We just did an interview with her in October last month, it's 2 months ago. And she was a participant, I think, 2 or 3 years ago. And what she said was, in the beginning, I hardly dared to do anything. I had lost all confidence in my body. Even standing on a wobble ball terrified me. Progress came little by little. She relearned how to balance, climb stairs, and even get on and off the bus. It may sound small, but it opens up your world. Suddenly, I could go to the city center or the library again. So this where, if you remember, we found these positive effects on balance, and for her this was a very important finding. She came in with a cane, and now she left without a cane, and her life really opens up again. So her advice is, take every chance you get. And if no one offers exercise, organize it yourself. For me, this program meant the difference between staying in bed and having a life again. Exercise is gold. If you want to make something of your life with cancer, it helps with fear, isolation, and it provides structure. I wish that for everyone. I will not show the video, so it's okay. We also have a video of Ineke, but because of technical issues, I will not show it. So again, if we go back to the conclusions, I think we can conclude that there are effects, it's cost effective, If you do group supervision, it's even more cost effective, and we think that it should be recommended as standard care during treatment for metastatic breast cancer. And last, I would like to finish with this slide, because I think that many of you are aware that we established the International Society of Exercise Oncology. Next year will be our inaugural conference in Heidelberg, and the abstract deadline is December 15th. So I hope to see you there.
Next week.
It's next week, yes. Good, thank you.
I'd like to invite any question from the floor. Does anybody have a question to end? It's okay.
아마 다
끝나고. After finishing the lecture, we will continue.
네, 그렇게.
And the next lecture.
So I will introduce the next speaker, Dr. Kristin Campbell. She received her PhD in the Department of Physical Therapy at the University of Alberta, specialized in exercise physiology and the oncology in 2006, and she's now a professor at the University of British Columbia in Canada. So, and her talk title is Exercise for People with Advanced Cancer, How to Translate Evidence into Practice. So audience, please welcome Dr. Campbell.
I will echo Anna's thanks to the organizing committee and Justin and all the students who have toured us around and shown us such a nice time in Korea. Today, my talk really will hopefully add to what we've already heard in terms of trying to move evidence into practice. It will build on some of the other presentations that we had already. And I think what my goal here is that for a long time, people with advanced cancer were not included in the trials, and so they didn't get a lot of opportunity for exercise, and also healthcare professionals didn't get a lot of opportunity to deliver programming to people with advanced cancer because there wasn't any evidence available. So the goal today is really to try and bridge those gaps. Let's see, will this work? Uh-oh. Will this advance the slide? That one, okay. All right, so today, literally to start with, just really talking a little bit about the unmet needs of people living with advanced cancer and the exercise professionals who want to provide that care, and then provide two examples of how our particular group has thought about trying to add to what is available for people living with cancer as well as providers. So the example first will be exercise for prescription for people with bone metastases, and the second example of just what we've learned when we've tried to take what we know from early stage cancer and apply it to advanced cancer and some of our learning on the way. So this is a quote from some of the individuals who've been part of various exercise programs. I was diagnosed with stage 4 palliative and essentially given up on exercise, which had been a huge part of my life. This program gave me a restart in a very supportive and safe environment, and for that I'm thankful. And I think that echoes what we heard just from some of the participants in the preferable trial. And then from a provider, this is kind of what we hear from our providers, like getting participants to learn and trust their body and feel safe and confident with moving, getting people to interact with each other and boost each other up was great. And so I think there's a lot of benefits for the provider to being able to provide this care as well. It's very gratifying. So we want to make sure we can do that better. To make sure we're all on the same page, advanced cancer, it refers to cancer that's spread beyond the primary site. Most advanced or stage 4 cancer is no longer amenable to curative intent treatment. And so the focus of treatment now is shifting from slowing cancer progression and improving or maintaining quality of life. And the goal here also is to have a multidisciplinary care team to really decide what is the sequencing of treatment and how to manage the side effects so people can stay on treatment longer, because at this stage, that is what is allowing them to extend their life. So in terms of unmet needs, this is a very short slide. There are many unmet needs, but for today, for people with advanced cancer, there is sequential treatments and a lot of high symptom burden that comes with that. Maintenance of functional independence and management of symptoms is consistently reported as a top priority for people living with metastatic or advanced cancer. And I think we heard that from the quote we just had from Anna May around being able to engage with life, go to the city center, take a bus. I mean, these are important elements that people want to maintain independence. And there is a lot of uncertainty when we talk about the benefits of activity around what is safe for that individual. For our exercise professionals, here I'm meaning physiotherapists, kinesiologists, clinical exercise physiologists, fitness instructors. There is some limited opportunities for training specifically for advanced cancer. So I think there's been a lot of improvement in the last 10 or 15 years, thanks to Thrive that we heard about yesterday from Dr. Culos-Reed, of getting available programming to train people to work with people with cancer. But now that we have more interest in providing care for people with advanced cancer, there is a bit of a lag then for dealing with the unique needs of people with advanced cancer. And so I think people are a little bit unsure when they start entering that space. A lot of uncertainty too about what is safe for people with advanced cancer, how much can you prescribe for people, how do we progress activity appropriately in that setting. Because ultimately there is wanting to avoid causing harm. And so there's a little bit of uncertainty there. So as more and more people are living with advanced cancer, because cancer treatments have improved so much in the last 5, 10, 15 years, people are living for a long time. And so I think we're seeing more people wanting to engage in this area. And so we need to be able to meet the needs. I'm going to talk about bone metastases very briefly here. Again, this is cancer metastases can happen anywhere in the body, but there is usually a common pattern. And for one of the places that the metastases can happen, it is to bone. And so for breast cancer, for example, here, vertebrae, femoral head, ribs are common places where the cancer metastasizes to bone. So you can imagine if you're an exercise physiologist, femoral head, squatting, standing up from a chair, ribs, twisting, these are all places that you're potentially concerned that there may be some bone architecture issues. So what do we do? So the first example of trying to take research and putting it into practice is our bone metastases work. We did some consensus recommendations, and then most recently have done knowledge mobilization approaches to try and move that research to practice. So this is our International Bone Metastases Exercise Working Group that met in 2018. It was led by myself, as well as Sarah Weller and Prue Cormie. And what the goal was here is we had done a lot of work for exercise in the early cancer space, but when we started to think about bone metastases, and this is well before Anna's preferable trial where you've put this into practice, how do we give guidance around what we know about exercise for people with bone metastases? So we brought together a multidisciplinary group, medical oncologists, radiation oncologists, physiotherapists, exercise professionals, social workers. Everybody was there to try and develop a recommendation. And one of the main problems we run into is that if there is bone metastases, people are very concerned about skeletal events, pathological fractures, spinal cord compressions. These are really very impactful adverse events. And so there's a lot of uncertainty around the right risk management profile. From the physician's end, they don't really know what to recommend. The exercise professional doesn't know what to do potentially. And so there was very little research to really guide what to do around exercise that was safe. There was a nice review in 2019 by Michelle Nadler, who is also from Canada. But at the end of the day, there was very little evidence to draw from. So what we sought out to do was a few different pieces to try and put it all together. We did a survey to physicians and nurse practitioners in British Columbia and asked them about their beliefs about activity, which majority thought was exercise is important for my patients. It has the potential to be safe. They also noted that 74% agreed that patients are asking them what to do. And 86 of them said they didn't really know what to say. And so this was definitely a gap on that end. We certainly know from our experience that if a physician encourages exercise, that is taken very seriously by the patient. They really listen to their physician and health teams. And so if the health team isn't feeling confident in recommending it, patients are very unlikely to want to engage in that without their approval. So this is a challenge. We also did an updated systematic review. There were a few more papers available. And overall, what we saw was exercise was safe, feasible, and beneficial for individuals living with bone metastases. They would be willing to go to programming, 70 to 80% attendance. They stayed in the programs. There were 4 serious adverse events in the multiple trials. None of them were related to the site of bone metastases. They were all from an intervention for soccer or football in Denmark. Things like Achilles ruptures, ankle fractures, so potentially some aggressive in men with prostate cancer, really enjoying their soccer, but there wasn't anything happening at the level of the bone metastases areas. And there wasn't enough evidence to be able to pool it in a meta-analysis, but there was some preliminary efficacy around physical function, muscular strength, quality of life, and fatigue. So that gave us some sense of it was possible, feasible, and beneficial. The last piece we did, and thank you if you were part of this Delphi and you replied to this, we did ask our international community about risk stratification, pre-exercise screening, exercise testing, prescription, and monitoring, and some thought processes that people had around that. Because there wasn't a lot of evidence, so we were really asking our clinicians around their experience and how they were approaching these things. The end result is 1 overall recommendation and 5 sub-recommendations. But ultimately, through 3 days of meetings, pulling all this information together, the recommendation really was that there is the potential to maintain and improve physical function and improve quality of life in people with bone metastases, and managing the perceived skeletal risks should be weighed against the potential health benefits. Everyone felt strongly that if we can do this well, this is a group who will benefit from exercise, and we just need to find a way to make it as safe as possible. There are 5 sub-recommendations. You can see them across the bottom about different elements of exercise prescription and monitoring. I will highlight one of those, and this is the key recommendation. This came up time and time again in our discussions, is the need for communication. And this is where there was a real breakdown. Our recommendation is, before exercise testing or training, perform a risk assessment to inform the likelihood of skeletal complication from exercise. So that sounds nice, but the difficulty is that everybody who's involved holds a different piece of information. So the majority of the health information, where are the bone metastases, the extent of the bone metastases, have they had treatment for that, is there planned treatment, what other pain medications are people taking, that healthcare professionals, the physician and the nurses hold that information. And a lot of the time our exercise professionals are working outside of the cancer care system. They can't see the medical record or they don't have access to that. And so they were left trying to get that information from the patient. Some patients are excellent historians. Others didn't know as much of the detail that the exercise professional wanted. Then the person themselves brings their own interests, goals, expectations. And so really what we were suggesting here is it needs to be a 3-way conversation to really make sure that everyone is on the same page and everyone sort of agreed to what is the goal, what is the cost, risk, benefit that we're willing to do. For some people, all they want to do is the activities they usually did before. They want to golf, they want to do ice skating, that is their priority. And so as the exercise professional, it's really our jobs to then how do we support that in the safest way and have the conversation that this is not risk-free. We will do our best and to give you the right information, but at the end of the day, this is something you have to decide. And including the healthcare professional in that whole conversation too. You have a sense of the progression for this patient. What things should we be considering? What's the trajectory? Where are we going with this? That type of thing. You can see here the team-based approach for the pre-exercise history. We suggested needed to look at lesion-related factors for the bone lesions, the cancer and cancer treatment-related factors, and then the person-related factors to really come up with a comprehensive picture. There is not one perfect answer of what it is. Everyone wanted a red light, yellow light, green light. if you have these symptoms, you're a green. If you have these symptoms, you're a red. It's impossible. The complexity of our patients in terms of their medical background, what experience they have with activity, what their goals are, it does not fit into an easy paradigm. So this is the approach. You need a conversation. It's not easy. I'm not naive that this conversation is easy to have. It's very sometimes difficult if you are outside the medical system to have the conversation with the oncologist. But the hope is that at least saying this should happen will allow you to say, this should happen. Please talk to me. But we know that guidelines alone are not enough to change practice. And we talked a little bit about this yesterday. So what we got then is we were supported by the Canadian Cancer Society to use an evidence-based co-design approach to develop something that was a knowledge mobilization tool, which means a patient handout potentially, but that's the term, knowledge mobilization tool. So that turned into the Bone Metastases and Exercise Hub, BME Hub. So for co-design, this is obviously not anything that is revolutionary in terms of people engage with their interest holders all the time. I think where the co-design process is, it's just very structured and really reminds you that all the way through to make sure there's checks and balances to make sure that you are getting the feedback from the interest holders. So in this case, it was people living with bone metastases, their family members, or people at risk of bone metastases. It was the healthcare team from the physicians, nurses, physiotherapists working in the health system, as well as our exercise professionals working outside in private practice who potentially would be providing the care. So we all came together. We did this very specific process around engaging people as we went. So with the evidence-based co-design, we first brought each interest group together on their own. So you talk about what it is as a patient with bone metastases, what are you interested in? If we know these recommendations have been published, what will help you use that information? The healthcare team were together, and then the people working in private practice were together. They all came up with their own priorities. Then we all met together, and we had to whittle it down because we could do 10 products, but that was too many. We only had so much bandwidth. So what was the agreed upon priority areas that we would do? And so we came to that. Then there was a lot of iteration. So different groups came together, multidisciplinary, to draft the materials. And then there's a lot of feedback processes around the right wording, the language that was used, the pictures that were used, the design of everything was a very key piece to the co-design. We were also fortunate to partner with the Canadian Cancer Society and their patient education team. So they brought a lot of experience around the right language, the layout, and how to best communicate some of the more complex tasks. So this is what it turned into. There are 5 products. There's an educational webinar. It's in English and French, because in Canada, it's a bilingual country. We have a patient handout, communication tool, which I will talk to more. The patient education video is how to use the communication tool. And we also have an exercise professional directory specific for Canada. So that is one potential thing that needs to be adjusted if you want to use this elsewhere. That is the QR code that will take you to the Bone Metastases Hub. We have done translations as well. So this has been translated to multiple languages from multiple countries. So a few people in the room, certainly Japan has been involved, and South Korea is coming soon. Justin and Rosa have been working on this, so thank you very much for that. We did run into some challenges of how to edit PDFs when you're using completely different languages, so that's where we are at now, but we've got a plan. And you can see here some other languages as well. So this is really I think something that we hadn't originally planned, and do thank Anna May for suggesting like AI translation as a starting point. So thank you for that. And then we have had people who speak that language and work in the healthcare system doing the editing to make sure that the language is correct. So if you don't see a language on here you're interested in, other than Korea, because it's happening, please let me know. I just wanted to focus specifically on this health information tool. This was the most complicated, because it was trying to support the conversation. And so what we ran into is a way to try and get the information to be shared amongst those 3 team members. We made it patient-led to try and avoid challenges around information sharing. So there's always privacy laws of what can be released by the physician or the healthcare system. And so to avoid that challenge, it's a patient-led form. They have the form, they go to their provider, it's filled in, and then they take it to the exercise professional. So they own it. The piece for the physicians, because no one likes filling in a form, it can't take very long, so we tried to keep it to the highlights. And so this is where it's supposed to complement a health history that the exercise professional is already doing. You don't need to tell me about their cardiovascular disease or diabetes. Like, I will ask those questions. What I need to hear from you, a medical oncology team, is where are the bone metastases, other treatment approaches, things that you're concerned about specific to that. And we did highlight that in the form. It does say this will complement a health history. So you don't feel like it doesn't have all the things you want to tell me. We will do some of that as well. And the last is just at the bottom. Because this is an advanced cancer setting, we did recognize that this form is completed at one point in time, and things can change. And so there is a statement at the bottom that if there are any changes to symptoms, pain is the example that's provided, talk to your healthcare professional or your exercise professional, and you may need to have a reevaluation. So, how successful this is, we're still working on trying to understand that, but this is an approach to try and solve that communication problem, and we'll see how well it's functioning. So the main outcomes from this is really the evaluation of the strategy for the tools themselves and our dissemination strategy. So we co-designed how we were going to get the word out as well. You can see here we had social media posts, we had conference presentations, and so the knowledge users, around 5,000 knowledge users for the first 12 months and over 13,000 views. And we were learning how to use some of the tools in the Google Analytics. It's very more complicated than you think, but here's just a timeline of some of the things that were undertaken as part of our dissemination strategy over the first 12 months. So lots of conference presentations and some other opportunities there. This is our Google Analytics. You're the first to see this. You can see here it was originally came out in May of 2024 for ACSM, and then was also presented at MASC in June of 2024. So that was the biggest intake that we had. But then over time, we've had a variety of different other activities that have kept the interest up. So this is our reach, and then this is our hub engagement. So we're learning about this, how long people actually stay on the website and use the tools. So you can see here it's about 60%. So when people go there, they actually use the tools. And so if you can get people there, then it may be beneficial. We also did some satisfaction with the tools. Before we released them, we asked people if they were willing to review them. And so they really said that the patient handout, the messaging was extremely clear or easy extremely easy or easy. The health information form purpose was well understood, and that helped to refine the final products as well. So if you are interested in this, there is an analysis underway around interviews for people who are using the tools. So if you are using these tools or want to check them out, and by the end of January, talk to someone about it. This is a postdoc in my team, Kelsey Bland, who's doing interviews, and she'd be happy to talk to you. This is what we found from one particular person right now. It has improved my overall confidence to prescribe exercise for this specific population, considering all the work and the serious research performed in this specific field in the last couple of years. So it is providing more confidence for our health providers to suggest exercise might be beneficial. We also have a professional development course that was part of this development as well. It is in English and soon in Spanish. It's about 10 hours long, and it's multiple modules, so you can pick and choose what might be useful for you. It is narrated by experts in the field, and it is free, so you're welcome to engage with that. We have also case studies. There are 4 case studies at the end where you can kind of work through the content and see about applying the skills in real-world settings. This is one particular individual with, I believe this is our lung cancer example, so you can see that. We are doing live question and answer sessions coming in 2026, so if you are interested in taking this course, I recommend you do it soon, and then we'll have some of those where you can ask any questions you have after doing the case studies at that time. And so again, we're just trying to monitor this as well. 100% satisfaction so far, which seems unrealistic really, but I think what this shows us, it's a free course and it's filling a gap. People do feel like this is something that they want more insights on, so overall people are happy, and it does feel that most people are feeling more confident and it's improved their knowledge, so that was a main goal of this activity. The course content is really clear and a lot of evidence, and the information is easy to use in practice, so that's a quote so far. The second example here is just how we've sort of thought about taking our early stage exercise programming and moving to the advanced cancer space, and what we've learned along the way, and how to better meet needs of a group that has different needs. And I think hearing Anna from the preferable around the emotional support and some of those things that still wasn't maybe moved by the intervention, that is similar to what we've been finding as well. So it's really helpful to understand that from you as well. This is some work we've done in advanced lung cancer. And so we used a live remote approach that we'd used for early stage cancer, and we just thought, and the lung cancer group was very interested, so we used a very similar approach. There were some adjustments, but a lot of the behavior change and some of the other social support elements, we kept the same. And so you can see here, it was for advanced lung cancer. We started out with a pilot study that has been published, and now it's a larger intervention. But you can see here is it virtual, 2 days a week, 12 weeks, and 60 minutes a class. And we provided tablets and internet support as needed. And the live remote, which we talked about yesterday, our instructors in the one corner, and everyone's doing their exercise at home. These are some preliminary results about satisfaction. So you can see here overall, satisfied. What was different potentially than some of our other groups here is that compared to our early stage cancer, the ability to continue on their own and were the weekly education elements helpful was lower satisfaction than we saw in some of our early stage breast cancer work. And so that did cause us to think, what do we need to do differently for this group? And I think what we've come away with is one, in the advanced cancer setting, and in advanced lung cancer specifically, this is a group where prognosis is potentially quite limited. And so the goal setting and things we did to try and get people doing it on their own was just not resonating for that group. And they really felt the need for having a safe space with educated professionals to do their activity. This was not a group that potentially we could discharge to a community program where they were mixed with early stage cancer, or they were going to find other programming in the community themselves. And then the education sessions just didn't resonate. So we were trying to figure out what to do. And I think, Nicole, you had said it's always this iteration as you go. And so that's what we've learned. So we're now thinking about how do we adjust that, and we were looking to another project we're involved with our colleagues at the University of Toronto. David, he's now in Calgary. Sorry, he's moved to where Nicole works now. David Langelier and Jennifer Jones in Toronto. And this was a different approach. It was a very rehab-based approach, and it was 8 weeks combined education and exercise. So now there was a lot more of an educational component to it that seems to have resonated with this group a little bit more. So I'll just highlight what the education component is. So what it is, it's a one time a week, either in person, exercise, and then it is 45 to 60 minutes of exercise, and then 45 minutes of education. So people come for about, can someone do the math for me, like close to 2 hours. They come once a week. For the virtual session, we realized that was too long for virtual, so they do a virtual exercise class that's 1 hour, and then they do an education session another time a week that's sort of 1 hour. And so this trial is a preference-based trial. We're trying to understand, do people want to come in person or virtually? But you can see across the bottom there, hopefully the text is maybe not big enough, but the first exercise class, it's goals, education, but you can see there's pain management, fatigue, brain health, nutrition, managing emotions, mindfulness, and planning for the future. And so it really is a bit more of a comprehensive rehabilitation approach that exercise is one component of, but there's these other pieces. And I think it has really resonated to address some of those other, the planning for a future is a hard conversation to have. And so I think those are the sort of things that we're sort of missing with some of the other programming that just wasn't a fit. So, preliminary results for the CARE-AC between our virtual and in-person is it's feasible. We had good retention, attendance, and no serious adverse events. But I think what's more important is kind of understanding what the experience has been. So this is a participant here. The greatest benefit that I derived is really from the physical exercise regime and learning how to stay physically active, even with limitations, as well as just socially connecting to other people similar to me and who get me. And I think that's similar for any chronic condition, and certainly we've seen that with early stage cancer, but I think the advanced cancer group really does feel that's an important element. So I think what we've learned for trying to take the early stage breast cancer or other early stage cancer work and moving it to the advanced cancer setting is that the patient education approaches may not translate as well, and we really need to be thoughtful about that and sort of understand a little bit more about what programming is the right fit. The need for continuing programming support to continue. So this group does feel less able to continue on their own and find community options. And I think there is more community options that are a fit now. Excel is a great one that has advanced cancer, but other programming is kind of catching up to being able to address the needs for advanced cancer. And I think right now, certainly in British Columbia, there's nowhere obvious to send people outside of something like Excel. The YMCA is not the place for this advanced cancer group. It just doesn't have the right setup. And then the last piece here, which I didn't talk about too much, is the need for excellent facilitators. That is what we found with the CARE-AC work, having those conversations about planning for the future, fatigue management, with you have serial lines of treatment. Our main facilitator was an occupational therapist who had a lot of experience working with chronic conditions. And so I think we need to support our clinicians and our exercise professionals to feel knowing what they feel comfortable talking about and partnering with some other clinicians who have experience with some of these different conversations that we aren't trained to have to really have the best effect. So on that note, this is the last thing I'll highlight here. So this is coming in the future. Kelsey Bland is a postdoc researcher with my group now. And one thing we've identified is kind of how do we provide exercise professionals with a little bit of additional guidance around working with people with advanced cancer. We've heard that from our clinicians. So she's looking at the limited knowledge gap and how the gap is mostly people working outside the cancer center. If you work at the lovely cancer hospital and all you see is people with cancer every day, you have a lot of clinical experience to bring. If you are working in the community, you see one or two people a month maybe, you just feel like you can't develop those skills as much and feel as confident. So this is some work that's funded by a small grant from the Women's Health Research Institute to train exercise professionals, equip them to manage complex patient needs, and improve the access and quality of rehabilitation or exercise programming. So this is another co-design process, so stay tuned, you may hear more about this, but this is a slightly different approach to co-design. It's called the Co-Design Toolkit, and here it's a workshop to start with, to sort of go with an overview and building kind of our safety around that. Second is gather, explore the knowledge gaps, learning needs, and the barriers. Third workshop is to understand what are the themes, how to prioritize, what resources are going to create for education. And the last is to improve, refining prototypes, evaluation, really getting the final product ready. So there's many different co-design frameworks. This is just one we've tried to use, so hopefully that might be of interest to you. So in summary, in terms of talking about working with people with advanced cancer, meeting the unmet needs for people living with advanced cancer and also our exercise professionals, people with advanced cancer have unique needs that need to be accommodated and thought about in our designs. The exercise and rehab professionals, we have the skills, but you need to provide more confidence in providing that training to really feel like you can address the needs most effectively. And these co-design qualitative support is trying to really make sure that the unmet needs are being met in the most effective way. So with that, just, I had a thank you slide, but I will just say thank you then and pass it on to our next presenter.
Okay, it was an excellent presentation. Thank you so much, Dr. Campbell. So we'll move on to the next and the last speaker.
It's my great pleasure to introduce Ki Yong An. assistant professor in Department of Kinesiology at the King's University in Canada. Dr. An is exercise oncology researcher with extensive expertise in cancer survivorship, physical activity, and health-related fitness outcomes. He previously served as research associate and postdoc fellow in exercise oncology research lab in University of Alberta, when he contributed to several large influence trials such as interval gap for IAPAC. And we will expect your great lecture, please.
Good morning, everyone. My name is Ki-Yong An. I'm a research associate at the University of Alberta. I would like to thank Dr. Justin John and organizing committee and staff and all the students in the exercise medicine and rehabilitation lab. Today I'll be presenting findings from the interval gap 4 trial with a particular focus on the quality of life outcomes. Substantial body of evidence demonstrate that exercise during cancer treatment improves a wide range of outcomes such as quality of life and even disease control and survival. And exercise is low toxicity, so it can be safely combined with other standard cancer therapies without additional significant treatment burden. So in prostate cancer, many studies have suggested that exercise could serve as an effective adjuvant therapy, but the majority of this evidence comes from observational studies. So this is why a rigorous randomized controlled trial was essential to clearly establish whether exercise can truly improve quality of life and cancer outcomes in these populations. But for advanced cancer, both patients and clinicians have often believed that exercise could be problematic or unsafe. So to address this concern, Dr. Daniel Galbao and his colleagues conducted a study and showed that structured resistance and aerobic exercise is safe and well tolerated and effective for improving physical function in men with bone metastatic prostate cancer. Moreover, a highly tailored exercise prescription using a modular and multimodal approach and avoiding excessive loading on the skeletal lesion has been shown to be safe and effective. So the primary objective was to determine whether the intervention increased overall survival. The intervention was supervised aerobic and resistance exercise with behavioral support, increased the overall survival compared to the control group in patients with advanced cancer, such as metastatic castrate-resistant prostate cancer or metastatic hormone-sensitive prostate cancer. And as a secondary objective, the study examined its effect on disease progression and skeletal-related event, pain, quality of life, and biomarker changes between the two groups. So based on these objectives, the study was developed as a larger scale international phase 3 randomized controlled trial aiming to enroll 866 participants. And to achieve this goal, an extensive collaborative network was established. So 13 research centers from 6 different countries recruited and randomized participants. And the intervention program included 96 weeks, almost 2 years of supervised high-intensity aerobic and resistance exercise program, and text-based behavioral support and psychosocial support through newsletters. And the control group received just ACSM exercise guidelines and recommendations and the same psychosocial support. So primary outcome was overall survival, and there are many secondary outcomes. So I know many of you are interested in the survival outcome, but today I'll focus on the quality of life outcomes. So we assessed quality of life every 3 months for 2 years, so a total of 9 time points using 2 different questionnaires. First one was European Organization for Research and Treatment of Cancer Quality of Life questionnaire, QIQ C30, that includes functional scales, symptom scales, and global health status, which is the primary QOL outcome today, and EPIC 26, expanded prostate cancer index composite 26, included prostate cancer specific domains such as urinary incontinence, urinary irritative, bowel function, sexual function, and hormonal function. This is the participant characteristics. Unfortunately, we were unable to reach the planned sample size of 866 due to stringent inclusion criteria and impact of COVID-19 and many other operational constraints. So recruitment was therefore closed after 7 years from 2016 to 2023 with a total of 145 participants randomized. So across age, race, physical activity level, and other clinical variables, 2 groups are generally well balanced. And only difference was time since diagnosis, which was a little bit longer in the intervention group. We used an adjusted linear mixed model to estimate the overall average intervention effect. So in this figure shows the between group difference. So if the graph is above the red line, which means the favorable effect for the intervention group. So only global health status showed the statistically significant difference, which is the red one, and emotional functioning and role functioning showed borderline significant differences, which are the yellow ones. And this is for EPIC domains, so there's no statistically significant results. And this is the time by group interaction effect. So each dot indicates each time point. And for the global health status, intervention group had a higher score at 6 months, 15 months, and 24 months, but the overall interaction effect was not significant. And for cognitive functioning, the intervention group had a higher score at 15 months, and the overall interaction effect was borderline significant. And for hormonal function, the intervention group had a higher score at only 18 months, and the overall interaction effect was not significant. So in conclusion, the exercise intervention led to a significant improvement in global health status, and the most other outcomes were not statistically significant, but the overall pattern showed a favorable trend for the intervention group. So these findings indicate a modest but meaningful quality of life benefit from supervised aerobic and resistance exercise with beneficial behavioral support in men with advanced prostate cancer. We gratefully acknowledge the guidance of co-chairs and the research funding support by Movember Foundation and all the dedicated effort of all the interval gap investigators. Thank you.
Thank you so much, Dr. Ki-Yong An. Now we will have open up the question and answer session all together. So please, the speakers come in and out. 교수님 좀 있으신가요? 저도 한두 개 있는데 질문이 많으실 것 같기도 하고 다른 분들이
듣다가 없으면
네 끼어들겠습니다.
미리 만들어놓고.
네. 궁금한 게 Okay, so audience, please feel free to raise your hands and please tell your name and your affiliation and ask any questions to the speakers.
Hi, my name is Dong-Woo Kim from Fred Hutchinson Cancer Center. Thanks for wonderful presentations today. I think I have questions for also MA and Kristin and everybody who work with metastatic cancer patients, and particularly, Anna, you showed us quite a lot of benefits in your studies and their pain, quality of life. Were there any particular outcomes that are clinically higher at baseline when you see those metastatic cancer patients compared to those who are not metastatic? For example, pain levels are much higher, for example, in the beginning for metastatic cancer patients versus other cancer types, or are there quite other outcomes that are prominent in cancer patients and from other experiences?
So, to be honest, we did not compare our baseline values with other settings, so perhaps that's a good idea. But on the other hand, it's always difficult to compare baseline levels because you have a selective population, and perhaps patients in the adjuvant setting enter programs because they also have complaints, and then the complaints are similar. So the only thing we did, we looked into the values we know that indicate elevated levels, and there we found that over 60% had pain, elevated levels of pain, and I can imagine that that is indeed higher than in the adjuvant setting. Yes.
One more question for other speakers. When you see those patients with the exercise intervention, did you personally see their patients or some complaints with the exercise? I feel like I come in too much of fatigue, or sometimes they feel bone pain, or did you see anything outstanding?
Yeah, I think that's a good question. The fatigue definitely, I think, is, it's hard to compare, like you're saying, but people are on treatment forever. So they're going through serial lines of treatment consistently. So I do think the fatigue that you'd hope to resolve if you were in the adjuvant setting, an early stage setting, that never happens. So I do feel like that's a key component. And the pain for bone metastases, sometimes people are symptomatic or not. But with exercise, one thing we had to talk about in the recommendations is people are usually taking pain medications of a variety of different types. So sometimes you would hear people taking more medications before they came to your class. And that is a sign that whatever is happening in the class is exacerbating their symptoms. And so really trying to understand the pattern. And if people are taking more medications preloading to come to your class, you may need to adjust your prescription for that person. So a lot of questions about that, and not just what's your pain now, are you doing anything different with your pain management?
For the GAP4 participants, they have bone metastasis in many parts. Here and there, like all different parts for each patient. So when we assess their muscular strength, we use the 1RM test. But for many patients, we just didn't do the real 1RM test, or we just skip that part. If they have some bone metastasis in their femur, we didn't do the leg extension test. And then when we prescribe the exercise program, also we avoid some resistant exercise for that part, or we changed or adjusted the loading we use some elastic band, or we use just body weight exercise, and we did some different low intensity exercise. So they are worried about the kind of like fracture or some different event for the skeletal part, and we also, that was kind of guideline of the exercise program. When they have some bone metastasis in some part, we just adjusted the exercise program.
Thank you.
Perhaps there's something I would like to add to what we discussed. I think that patients with advanced disease could be a very different group. So, for example, breast cancer with advanced disease treated in first line, they can, Ineke, for example, she's now living on her first line treatment already for 3 or 4 years, and it's hormonal treatment. That's very different to, for example, patients with esophageal cancer. We do a trial in these patients, and their disease progression happens often within months. And there we need to adapt the exercise program to their situation more often. And it's also, we experience that they have more severe fatigue, for example, as compared to the breast cancer patients. So I think it's really a very diverse group, and that we should take should keep in our mind.
Thank you for 3 excellent presentations. I think this is very meaningful and memorable because, Dr. Yang, Eunju, and our committee, when we were, organizing this together, we thought it was quite interesting that we have a world experts in the, advanced cancer, and then, and it's really good to see now we have 3 excellent presentations on advanced cancer. So when I was actually doing the on-call run, running for cancer patients, surprisingly many metastatic cancer participants were there, and then they look wonderful, like they look very healthy. So I think many times we health professional, like when they say, oh, it's metastatic cancer, like, they must be really fragile, and maybe we need to be really careful. Of course, we need to be careful, but then the people who came to our program look much better than I ever expected. So what kind of, is that some experience that you also see? But of course, I mean, there's people, as you mentioned in your preferable study, almost 20% they passed away in first 6 months. So there's quite a variation. So, I mean, what is your thought on that?
Yeah, and then we had this estimated life expectancy of 6 months. So that when they came in the study, their oncologist estimated their life expectancy to be longer than 6 months. And indeed, 14% passed, or something like that, passed away early. And that you couldn't see at that moment or estimate. But perhaps you want to...
Yeah, I think it's a really important point that, as you said, Anna, some people are managing quite well on their first-line treatment, and so they could live on that for a long period of time. And so I think to your question, that's where the blanket statement of, like, do you have bone metastases, yes, no, and then if it's yes, you're not eligible, you're not included, has been the limitation. And I think what you're seeing is exactly that some people are functioning well, they don't have any symptoms from their bone metastases, and they're looking at you like, why are you limiting what I can do? And so I think that's where having the conversations, understanding what's happening for that person, and really understanding their goals, because some people just want to do all the things they did before, and so then we're putting up roadblocks, and they're not getting advantage of some of the things they like to do for fear of fracture, which is a very realistic fear. But I think then that really limits people, maybe needlessly. So that would be what I'd say to that.
As Kristin said, that was the same for our GAP4 participants. Before they started the intervention program, they are worried about how can I do this high intensity resistance exercise? I have bone metastasis. But once they started, like they feel like, oh, I can do it, and it's not that hard. So some participants, it was the same. They wanted to do more, but there was a protocol. We couldn't do the more like resistance exercise for the bone metastasis part. So, and then they can do most of the exercise, like for the aerobics, they can walk, run, bike, and everything. And then for the resistance exercise, I think they can do more, but by the protocol, we limited the exercise. And then their condition is more depends on their treatment, I think. The bone metastasis itself is not, it doesn't limit their like function and their capacity. And I think, but when they're on treatment, like chemotherapy or something, and then their condition is really bad and they don't want to do the exercise, they want to take a rest, fatigue, a lot of fatigue and pains, but not because of the bone metastasis.
Sure. So,
I just had one thing to that. Sorry, I am just like, I totally forgot what I was going to say. It's like, yes, the mic was passed to me. What was I going to say on that front? Oh my God.
that's okay. I can ask the next question and then you can think about
yes.
it. Yeah. So, yeah, this question goes to Anna May, but then also, anybody, else can answer the question because you did a cost analysis, and you were showing that 1 to 4 was more cost effective, which is of course. But yesterday we hear from Georg and also many other presenters. The social, side of exercise intervention is actually better than and maybe more effective than we think it is. So actually, it's not a bad thing. Maybe if, instead of 1-on-1, actually 1 to 4 or even 1 to 5 or more. So what is your thought on that?
Yes, I'm very much in favor of group exercise. Also because I don't think that a person needs a constant supervision. If you know your program and there's an exercise specialist present in the room, you can just do your exercises. And then there's always this question, do you want to have these group exercises with peers or just in a fitness group? And there we learned that there is not one answer. So some prefer to do that with other patients, some prefer that in just a group. And for example, Ineke, she did her exercise at a physiotherapist center with many other people being there for other reasons than having metastatic cancer. And one thing, and I didn't show that today, but what I also liked very much is that Ineke had bone metastasis here in her cervical spine, so she was fixed and she couldn't do this movement anymore. And if you bike, you need to sit like this on your bike. And we had high intensity exercise on a cycloergometer, but she couldn't do it. And then there was a welder just there doing his exercises for something else. And he said, but I can build something for you. And he built a handle that she now could sit, that had a fit with her new anatomic situation. And by that she could do the exercise. And this is just one example, but that was so nice for her, for being together with people and helping each other. So I think indeed that group exercise. We have physiological effects of exercise, but there are also some psychological benefits.
Hello, I'm Sung-ri, a PhD student of Professor Justin. I have just simple 2 questions to the last speaker, Dr. An. First, I was really interested in your research because it's, the very large-scale RCT, and I really appreciate your fascinating presentation today. The first question is, is this the first phase 3 RCT for prostate cancer, or just? As far as I know. Okay.
Yes.
Okay, thank you. Okay, like the challenge trial for colorectal cancer. Yeah. Okay, and the second question is, if possible, could you share a little bit of the result for the primary outcome of your research, overall survival? Yeah.
I'm not allowed to do that. And actually, it's in progress. I don't know the result yet. They are doing the analysis now, and this is I think there are trying to publish feasibility results now, and this is, I think, the second paper about the result. They published some protocol paper and some like preliminary data, but this paper is also in progress now, so we don't know the result yet. So this is basically same concept with challenge trial. So challenge trial is for colorectal cancer, and this is for prostate cancer. But unfortunately, this trial couldn't reach the planned sample size, so it was only 145 participants out of 800. So I don't know what the results will be, but yeah, stay tuned. Yeah, you can. The results will be released soon.
Thank you for your answer. Thank you very much for the presentations. My question is for Professor Campbell. I think it's wonderful that we are providing these additional resources for CPs like myself to have confidence to deliver exercise interventions for individuals living with metastatic cancer. One thought that I've had as a CP, and for CP who is not in the research context, there's not much of an incentive for a CP to pursue a career in ex-onc at this moment, because there's no support, there's no infrastructure. Do you have any thoughts on how we can address that in the future? If our goal is to create this community and infrastructure where we have a patient and now, okay, go see this person, go to this group-based program. But if there's no incentive for professionals, how do you think we could go about addressing that?
Yeah, it's a great question, and I would say it's the same for physiotherapists. It's a chicken and egg. People get excited about this area, they do all the training, and then they go out to practice and they don't see a lot of cancer patients because no one is referring them to their services. I think fundamentally part of it is reimbursement. So even if you are a physiotherapist, if you have extended health, then you can go and access that, and so people will take advantage of that. But the oncologists are very reluctant to refer people to anything that costs additional money, at least in the Canadian context, because even though we are in a public healthcare system that covers most of the treatment, there is, you're not working, you may have additional transportation costs to get treatment, like it's quite a financial burden. And so our oncologists tell us time and time again, if it's not free, they do not want to refer people to things, or they don't have extended health. And so I think that's a main barrier to working in the community. There's nowhere for you to work because there's no people coming to see you. And so that's what a main challenge is. So I think to answer your question, there's no easy fix to that. But I think something like the challenge trial, where now it's seen as an important part of treatment. This has impacts on treatment outcomes. Maybe allow us to move the needle slightly to make it a priority that's either related to the cancer center, or there is a pathway to fund people through their extended health or disability insurance or something to provide the opportunity for you to provide the care. So I don't know if other people have other senses of, in the Netherlands, if it's any different.
I think it really depends on the country. So in the Netherlands, we now see that patients are referred to physiotherapists to have an oncological training. So we have a network and we have a map where patients can look up physiotherapists close to their home. So I think it's better now compared to 5 to 10 years or 10 years ago, but the reimbursement still is the biggest issue. So patients are going, but I think we cannot reach everyone because of this issue. So that is really my priority for the next 1 and 2 years to change that. But it might be longer than 1 or 2 years, but I think it's the most important thing we should do. And then there will also be, value for what you are doing.
You have key coordinator program in the Netherlands, and I read some paper from you, and thank you very much for this opportunity to meet these big guys, because I read your paper and I met you the video clip on lecture on mask. So I expected to see the translated Korean version. So you, oh, thank you very much. Thank you.
Almost done there.
Yeah, almost done. Yes. As a pediatrist working at University Hospital, I got many consultations from oncologists. So they have many bone meta and spine meta, and they are very they are very anxious, anxiety. And so I use SINS score to see the stability, and I want to. Sometimes I prescribe brace, and I modify the transfer, and I sometimes I recommend the propagate pattern for them. So in your trials and your experience, do you use some score to measure the safety to practical point? And I'm very curious about that. Both of you.
No, I think that's a very good question. And when we met as the working group, we wanted there to be a score. And so the SIN score, the Morel score, these are scores that the radiologists use to decide sort of how extensive the bone metastases is and sort of whether it needs fixation or some other treatments. The challenge we ran into is that those have never really been linked to activity or physical activity or exercise. So they are helpful, but we didn't know if a SIN score is X, how does that relate to a serious adverse event with an exercise intervention? And so there wasn't any information from trials or practice that we could use to get that was very clear. So I think they're useful, and but we didn't know how to say this and this. The other thing that we heard, and this may be different in Korea, is a lot of that scoring is not done for patients. So the radiologist looks at the bone metastases and is like, I don't know what they do or what they write down. And so sometimes everyone thinks that obviously the Morel score or SINS is there for everyone. And we heard from our oncology and our physiatrists that it's rarely in the chart. And so that turned into a barrier, I think, in the Netherlands around needing that score and what that meant. And maybe Anna can speak to that because it's very interesting.
Yeah, I think that I have nothing to add.
Oh,
yeah.
Wasn't there something like you needed to have that score or something? Martin, no, we can talk
Yeah,
about
I know that we had a question whether we had the score, but we didn't have it for all patients. And so the question we just put for our preferable study to the medical team, do you score this bone metastasis as stable? But we didn't ask for a score or a threshold. It was more or less the judgment of the medical team. And if it was not stable, if they score it as not stable, in our trial, patients were not allowed to enter.
So I think that we need some translation form to between the oncologist and exercise trainee and patient.
And physiatrists.
And physiatrists, yes. So team approach is very helpful for the patients, but the word is different. So we have we need some common language and translation data sometimes.
Agreed.
So I thank you very much to meet this. Thank you. And any other question from the floor?
I think we have few more minutes. Okay, so then I'll do the wrapping up questions. So since we are focusing on the metastatic cancer, so I want to know what's the caveat, the cautions when we design exercise intervention, especially for the metastatic cancer rather than the first, like a primary cancer.
I would think one thing you should take in mind is that you can design an intervention and you can plan for progression, but there is also progression of disease. So you need to really also describe that you can adjust the protocol based on the patient's progression. That helps the physiotherapist or the exercise specialist, but also the patients, that they are not disappointed that they cannot do the protocol. So also if you score adherence to a protocol, you need to think that if disease progresses, it means that perhaps you cannot progress with the protocol you had in mind. So it needs to be adapted to the patient situation. So I think that's, for me, an important issue.
Thank you so much again for the speakers. Let's give an applause for the speakers and let's have a break.
Thank you for that question. I think that is some of our next research. So maybe I will reach out to you if you are interested. Yeah, so I will ask Kristin to help connect.
and cancer care. It is my pleasure to introduce our session chairs, Dr. Sang-Hui Chu at College of Nursing, Yonsei University. Oh, sorry.
Nobody's listening.
Oh, sorry. Yeah, I thought they were. If you could find your seats, please, we'll begin shortly. Welcome back, everyone. We will now begin session 2, Lifestyle Pathways to Sallutogenesis in Cancer Care. It is my pleasure to introduce our session chairs, Dr. Sang-Hui Chu at College of Nursing, Yonsei University, and Dr. Hoon Lee, Department of Sport Industry Studies, Yonsei University. Please welcome our chairs. Chairs, the floor is now yours.
Hello, everyone. Welcome back. I'm Sang-Hui Chu from the Yonsei University, College of Nursing. It is my pleasure to chair the last session of the symposium with my co-chair, Professor Dong-Hoon Lee from Department Sports-led Industry Studies from Yonsei University. Our session is titled Lifestyle Pathways to Salutogenesis in Cancer Care. In the next 90 minutes, we'll explore how work environment, psychosocial stress, physical activity, and social network and diet all contribute to the salutogenic pathways. We have 3 excellent speakers from University of Zurich and University of Seoul National University. Our first speaker is Professor Georg Bauer, head of the Division of Public and Organizational Health and head of the Center of Salutogenesis at the University of Zurich. He is internationally recognized for his pioneering work in salutogenesis and organizational health development. Please join me welcoming Dr. Bauer to the podium.
Okay, good morning everyone again. I already had the opportunity to speak here yesterday, but again, another thanks for inviting me. Probably you are wondering why I'm now giving a second talk and even on such a strange topic such as health at work and in organizations. Only vaguely maybe related to your topic, but then I thought there are actually 3 good reasons to give this talk here. First of all, I'm really impressed about the level of engagement and dedication you all show to your own job, really serving and working with people affected by cancer. And that really requires a high level of engagement, and I think you all can only thrive by good working conditions. And so maybe my talk gives you some ideas how to sustain this good promoting or motivating work environment. So that's the first reason I think why this talk makes sense. Secondly, I mean, for cancer patients also, they might be affected in their ability to work. And again, also acknowledging that ideally maintaining the ability to work and how this loss of ability to work also might affect the progression of cancer, I think is something which could and should be considered in your research. I don't know in how far you do it already, but again, that might also give some ideas how you could assess the quality of working life of your patients in future studies as an additional predictor of future outcomes, and I think it's even closely related to exercise in the end. And last not least, I heard in the last symposium I had here, there was some discussion, is salutogenesis theory at all? And I think I can now demonstrate by applying salutogenesis to a specific context of working life and organizations, we are really capable of testing the theory, because when it's specified for this context, and we can do actually quite good, I hope, empirical research. That would be working. Let me see here. Yeah, that works better. Already yesterday, I introduced these 3 meanings of salutogenesis, and now I will certainly just build off them. On the one hand, you will see when I present our research now, we certainly always focus on the salutogenic orientation. So we always focus on strengthening resources in the work environment and looking into positive health outcomes at work, and not only or primarily only into stress. And you will see also during this presentation why we do so. Secondly, sense of coherence is a generic concept with global orientation to life, and that we will apply specifically to the working context in a minute. And last not least, as I promised, I will specify this model of salutogenesis for work. So this is actually the 3 sections. First, I will introduce this idea of a work-related sense of coherence, so how you perceive your working life as coherent. Secondly, I will introduce this job demands resource health model, which is basically the salutogenic model applied to work. And last not least, I will go into practice how you can apply that to improve working life. So what is this work-related sense of coherence about? I mean, yesterday we learned sense of coherence generally is a global orientation to life, how I overall perceive my life as comprehensible, as manageable, and as meaningful. So certainly this level of coherence is very much influenced by coherence across your life domains. So maybe you have a very coherent family life, but on the other hand, your working life might be chaotic, overwhelming and everything, and that both will contribute then to your overall sense of coherence. So it does make sense to decompose the sense of coherence for different settings, and there already have been scales, for example, related to family sense of coherence, so how coherent you perceive your family life. Others have tried it also for leisure time, and we proposed it for work life. So the basic idea is when we now enter our work, where we are exposed to certain working conditions, where our job demands things which require our attention, our energy, which might also stress us. And on the other hand, there are resources in the work environment which give us energy and allow us to achieve our goals. And this balance of job demands and resources will heavily influence how I perceive my job as comprehensible, manageable, and meaningful. So it will really be influenced by these working conditions on the one hand, and secondly, it will also certainly be influenced by my general sense of coherence. So if this is already very high, I might be even better able to really even deal with very difficult working conditions. So also my work-related sense of coherence will also be influenced by this generic sense of coherence. So it's an interactive concept, this work-related sense of coherence, influenced both by working life and the underlying generic sense of coherence. And why is it an advantage to measure this work-related sense of coherence? As it depends also on the quality of the working conditions offered by the employer, so to speak, it's a much more sensitive measure for the quality of working life and can be also used in intervention studies. So that was our idea, to develop such a concept and also instrument. So when we developed this instrument, and as any of you who did some work already with companies, scales in the company context always need to be very concise, very brief, and this is why we really developed this scale where we always have these opposing terms of, for example, my job is manageable, unmanageable, meaningful, meaningless, and then people can assess how far this really applies to their own job. So it's a greatly simplified version of the original sense of coherence scale, which is consisting of long sentences. We really focus on the essence of these different dimensions of the sense of coherence, specified for working life. We developed this scale that has very good reliability with scale and also the desired three-dimensional structure when you do factor analysis. Now, does it show the kind of relationships which we expected? Here, that's a longitudinal study with 6-month time intervals, and we measured sense of coherence at the bottom at each of this time point. Then we measured the work-related sense of coherence, and as we are very resource-oriented, we measured the job resources at each of these measurement points. And that's a structural equation model, which really is looking at all these relationships simultaneously and is producing the best model fit. And what we see, as expected, on the bottom, the general sense of coherence, that's quite stable over time. So this relationship with, oh, sorry, now it moved on. Why did it do that? With path coefficients here, you can roughly interpret as a correlation. So 1 would be the maximum association you can get. And as you can see here, so SOC is very stable over time. Over time, they are really very strongly related with level. And as we would have predicted, the work-related sense of coherence is much more fluctuating, so it's not so stable over time. but that it can be explained because also the job resources on the very top also change over time. So really, as we predicted, work-related sense of coherence is influenced both by job resources going, I don't really know why it always jumps on when I show something, but here job resources are predicting the work-related sense of coherence, and the sense of coherence, the generic, are predicting the sense of coherence. So as expected, it's really an interactive construct influenced by both the working conditions and our generic sense of coherence. Now, when we did some further testing, that's basically the salutogenic model of health, now really specified for the working conditions, where you see the two main paths of job resources, which go towards positive health, what I showed yesterday, this expanded model of health. On the bottom, we would have this original model, where we have job demands, stressors, which would lead to negative health outcomes, but certainly also job resources would help us to deal with these job demands when we would have less of these negative health outcomes. And in the center, the sense of coherence is certainly moderating and mediating all these relationships. So that's the overall model specified for the work context. And now we did a lot of empirical studies, and certainly I cannot show all the studies in detail, so I just summarize the results. And you find the details also in our handbook chapters on salutogenesis related to work. So anyway, in these different studies which are listed here, we could show that the work-related sense of coherence is indeed influenced by job resources. So if job resources are strong and high, we have a more stronger work-related sense of coherence. And on the other hand, if job demands, the stresses are high, this is impeding the level of work-related sense of coherence. So we really can consider this very simple condensed scale, just with 9 items, as a good indicator of quality of working life, of the balance of job demands and resources. I think that's quite useful if you don't have a lot of space in your questionnaire to just focus on this work-related sense of coherence as an overarching indicator of quality of working life. Secondly, we could show if this work-related sense of coherence is strong, then also we have more positive health outcomes, such as being more satisfied at work, more engaged at work, having a better well-being at work. And on the other hand, it also is really reducing negative health outcomes, such as burnout or also different musculoskeletal pain experiences related to work. And last not least, a strong work-related sense of coherence over time is also building up resources, exactly as predicted by Antonovsky. A strong sense of coherence at work will help you to develop and broaden the resources you experience at work over time. And we also have seen that in the previous study, that when you have a strong work-related sense of coherence, good working conditions, that also helps you to strengthen and build up the general sense of coherence over time. So work in life is really also a key source of health through the sense of coherence over time. Yeah, and then it's also certainly moderating with relationships. A strong sense of coherence allows us indeed to mobilize, identify more resources at job and to better thrive at work, as again predicted by the salutogenic model. So I hope I could show you by that first section of my presentation that indeed the salutogenic model can be tested, and all these relationships predicted by Antonovsky we could prove really for the working context. And I think also what I would really conclude here in this first section, that using this work-related sense of coherence scale in research is very useful, because again, with just 9 items you get a very good overarching indicator of quality of working life, which is very much really reflecting the level of job demands and resources on the one hand, and at the same time it's very predictive of work-related outcomes. So I think that's a good tool to use in the future. Has been also translated in various languages and used in many more studies by now. If you want to use this idea of sense of coherence in a more qualitative sense, that can also be done. I like also this study because it also has been done with actually healthcare professionals, with our colleagues actually from Israel. And they did some focus groups, group discussions with people in a nursing unit, in a psychiatric, in this case, inpatient nursing unit. And they use this framework to get a good understanding about the quality of working life perceived by these nurses working there. And there you see they used this kind of interview guide. So what really helps you to have a comprehensible job, what helps you to have a manageable job, and what helps you to find meaning in your job. And then based on this structured assessment, they developed also interventions to improve these 3 dimensions of the sense of coherence. Again, it can also be used in a very qualitative way if you want to do that in your future. Could also certainly be applied, I'm just thinking now, when you engage with cancer patients, you could also ask certainly how comprehensible did you find our intervention, was it manageable, and did you find more meaning through that? Again, it could also be a good framework for that. Yeah, then we went one step further because I think it's a great tool for research. In practice, often we found that people understand well these 3 dimensions of the sense of coherence because it somehow resonates. Sure, I need to understand my job, and I somehow need to be able to manage it, and it's good when I find some meaning. But then again, this very term of coherence didn't really resonate well. So some people really had difficult understanding, what do you mean by coherence? And so sometimes we thought, well, that's maybe not the best framework to use in certain company contexts. We found out it works really well, particularly in the healthcare context, because more and more people in healthcare know already about salutogenesis. And then when we do studies with healthcare workers, it worked very well. Also with teachers, also in education, salutogenesis is more and more known. It worked very well, but in hardcore business, often they didn't understand what we are talking about. So this is why we went with next level, let's say an alternative path, focusing more on this idea of the balance of job demands, resources, and not going so much along the lines of the sense of coherence. I think I already showed you this completed salutogenic model of health yesterday, where again the basic idea, what I also just showed in my previous slides, is that on the one hand we do have with life stresses, with demands also at work, leading to negative health outcomes. That would be the one path of pathogenic health development. And luckily we do have these resources which help us to overcome difficult situations, which would be the coping path in the salutogenic model, and we also would have immediate positive outcomes of good working conditions. Now the interesting part is that the salutogenic model of health developed in the 1970s and 80s. And in 2007, some people in a completely different field came up with this model here, which might sound a little bit similar. It's the so-called job demands resource model. And these people never made any reference towards salutogenesis, which I found interesting because it's very much the same thinking. So you have demands at the job, and they defined it in a very concise way. Job demands are those aspects of your job which you value negatively, which are straining you, exhausting you. And normally they look only at burnout as the final outcome because they are psychologists, the authors of this model. And then again, if we talk about resources, what we now saw as resistance and thriving resources, they also define resources as those aspects of working life which help you to overcome demands in your job, so you are less exhausted, but at the same time these resources will help you to achieve your goals at work and also to develop personally at work, and then you are more engaged. And the only outcome they normally look into is motivation measured by job engagement. Then we thought, great model, and it overlaps so much with our model we normally use. Let's bring it together and just expand it a little bit because we, as I said, only focus on psychological outcomes of burnout and engagement. And so we postulated that we could really expand it towards a job demands resource health model, which is really still the essence of the salutogenic model, just leaving out here the sense of coherence. And so, over time, we used this model repeatedly in our research. Meanwhile, I think it's really a very well-tested theory where we can show these key relationships also empirically. Here I show data really from a big intervention study. We were contracted to evaluate a multi-level stress intervention study in 8 big companies in Switzerland, known companies such as Nestle, but also big production companies, 2 hospitals, and even an administration, a big government administration office. Now you can imagine if in all these different sectors and companies, people have quite diverse working conditions. And we were still challenged to find some common ground. So what are the stresses which would prevail in each of the sectors? But even let's think in a hospital, we have the cleaning staff, people cooking, the nurses, the doctors, I mean, such a diversity of people. And are there still commonalities across all these jobs? And through different methods, quantitatively, qualitatively, we really were able to identify the key job demands and the key job resources which play out across all these jobs, and probably things you all know from your own working life. So let's start with the job demands we've identified as really the essence, happening over and over again. It really has to do with the high level, intensity of work, the time pressure, the role uncertainty, you don't really know what is expected from you, and the qualitative overload, which means you are not sufficiently qualified for what you need to do. So these are the common stresses across all these different professions, really stable across gender, different job categories, and so on. And now what we see here is these job demands indeed have, again, with a structural equation model where you can interpret with numbers here roughly like correlations. So 3.5 is a kind of medium-sized association we find on the top between job demands and negative health outcomes. And here we look in quite common negative health outcomes at work where people are so stressed that they cannot sleep well, they feel exhausted. This is a burnout indicator. And also they experience a lot of musculoskeletal disorders, back and neck pain, which is also quite common at work. And so we have a medium-sized association here. Now let's look at the bright side, the thriving factors that would be at the bottom. What are the key resources, again, playing out across all jobs? Certainly, it also has to do with our task, what we do. We want to have a complete task, a holistic task, not a very fragmented job. And we also want to have some control, so autonomy, how we do our job, not a boss who tells us exactly what to do and how to do, okay? So that's really on the task level. But much more important even is the social environment at work also, that you get both appreciation and also support by your colleagues and by your supervisors. That's really the strongest, most powerful resource you can have at work. And if these resources are strong, on the one hand, we have this path going up from the bottom left to the top, minus 0.43, which means despite having high demands at job and with stresses, which you see here, when you have at the same time with strong resources, this is really buffering the negative effect. So if there's a negative relationships, you have much less of this negative health outcomes. So even if you cannot change demands, boosting with resources will really assure that there's much less damage done to your employees. So that's the first powerful function of resources, exactly, again, as predicted by Antonovsky, that certainly resources would help us to cope with this difficult situation. The second relationship is then at the bottom. If these resources are really strongly developed, it has a huge, very strong association with the positive experience of your job. So you feel satisfied, committed, even enthusiastic about your job, which certainly also we can show it's very much predicting also performance in the long run. And there is a huge relationship that would be the second power of the resource. And the third power is then going from resources to demands, the blue arrow, okay? What does it mean, this negative association here? Well, it's obvious. When you are working in a good environment where you really communicate openly with each other and have this trustful environment where you get appreciation and support, you will certainly address if there is a role unclarity. You will address if you are stressed and have too much to do. And in that environment, demands are really diminished from the beginning at the source already. So this is why I call it triple power of resources, because strengthening resources at work will diminish the negative impact, it will diminish the stresses in the very source, and it will contribute to the best possible work experience. So I think it's a very strong argument for the salutogenic orientation at work, and we can show it here really empirically. Yes, so much for the research. I think I will obviously, I still have like 10 minutes. Yeah, so this is why we now can actually come to apply it in practice. When you now want to translate that, I cannot really show the graph I just have shown to you as researchers in a company. So in a company, we need to have a much more simple storyline. And here we can refer to Kurt Lewin, Some of you might know he is one of the first psychologists who really co-created the field of psychology in the 1920s. And interestingly enough, he went into assembly lines of the Ford automobile companies in the US and was observing people in how they perceive their job. So really was doing observations and also asked these people, how do you like their job? And out of his research, there emerged this model of 2 phases of work, which is exactly what people proposed in 2006 as a job demands resource model. It's the very same idea already 100 years earlier. He has learned from these people, yes, indeed, some things in this job as an assembly line worker are really pulling us down, exhausting us, and really damaging us. But there are also very good positive aspects which give us energy and let us thrive at these assembly lines. Okay, and with that story, you can go into a company. Everyone can relate with both sides of a work, 2 phases of work, because everyone is experienced that on an everyday level. And then we can say very simply, well, then our simple goal is let's take a look at these demands and resources and bring it into a better balance. Because when they are balanced, then certainly we all will benefit by that. So when we use that as a little bit more, let's say, differentiated mental model for the managers and say, well, nowadays it's just not good enough to only reduce stressors and reduce stress, because then you might have very relieved people who are not stressed, they don't have tension, but still they are not engaged. So in addition, you need to really boost the job resources, because only those resources allow your employees to really do their job well, to achieve the goals set by the company, but also personal goals. So in the end, we need to do both, reduce unnecessary demands and boost the resources which help us to be engaged. And if you do so, you produce both health for the individual employees, but also a sustainable performance for the company, which also can be shown empirically. And that's the first message, again, a little bit more differentiated. We need to balance with job demands and resources. And the second key argument here is that really both sides are needed to achieve that. Because often what is happening when you talk about stress and stress-related research, stress is always in the eye of the beholder. So you are stressed, so it's your fault you are stressed, okay? But this model really shows, no, this level of job demands resources is really created by both the employees, how they work, but very much also by the company, what kind of working conditions the company is offering. So both need to work together to improve this work. Job demands balance, okay? I think that's a very powerful message also, that there's a shared responsibility. Then you need to be able to measure that in a concise way. So we developed a very short questionnaire assessing these key demands, which I showed before, on the key job resources. Then you can sum them up. You build an average of the resources and the average of these demands, and then you build a ratio. You divide the amount of resources by the amount of demands. By that you get this job demands resource ratio. And evidently, as bigger the number is, it's better, because then the resources prevail over the demands. And what we can show empirically, if you get more into the green zone, so the resources are stronger than the demands, then you have less exhaustion, less absenteeism, more engagement, and more productivity in firms. So it's also a very simple and powerful message to the company that it's worthwhile investing in balancing with demands and resources. And how can you do that? After you have measured it, you should take some action. And we found out over time it works best when first we work with the managers themselves, because all the managers are quite stressed. They are really having a lot of responsibility, very little time, and often they also neglect their own health. So we really need first to start out with the health of the managers, not because they are the most important in a value sense, but because they are the decision makers. And if we don't get their buy-in, we won't be able to do anything with the employees. So we experienced, when we do workshops after assessing also the demands and resources of the management level, and then they came together and exchanged about the results. So it was already very relieving that not only the individual manager felt stressed, but he or she noticed, others are also in the same situation. We are all in the same boat. So maybe we can also change something. And that then always leads to a very creative process of really creating ideas how we can diminish unnecessary demands and strengthen our resources. So, for example, they introduce regularly in team meetings a time where they also exchange how well they can perform, how much they feel engaged, and what is really also stressing them unnecessarily, and always talk about possible solutions to improve their working life. And after they have done that for themselves, they are highly motivated and also capable running the same kind of process within their own teams. So when we send them out and they do again an assessment on the team level about these job demands, resources, and they moderate a process where they develop ideas for improving this balance in the next step. Yeah, to sum that up, I think when we now think about a salutogenic organization, I think it's really very wise, following the salutogenic model of health, to create consistency in the sense that you need to have a very simple mental model what makes for a good, healthy organization. And I suggested already, there's two phases of work. Having good balance between demands and resources is very powerful. And we heard often, we did this kind of studies even with banks, Swiss banks, which are certainly very money-driven, okay? And then after they have went through this process with us, they suddenly told us that often when they now take management decisions, they also reflect how is it really affecting the balance between job demands and resources of our employees. So we do not overburden them because then they lose completely their productivity. So that really is then becoming part of the DNA of a company when you have this simple mental model they can think about on an everyday basis. On a load balance level, as we saw, it's really about balancing with job demands and resources. And last not least, to create meaningfulness, we know that we need to actively involve people so they are in the driving seat for improving their own working life. And I have shown you briefly how you could do that through running workshops where really people themselves develop solutions to improve their working life. So do I still have 2 more minutes? Then I would still show the latest development. As you have seen now, we did a lot of work on the group level with managers and teams. And lately there's a very new development I just would like to briefly share, which is this crafting approach. You all know certainly about coping. Coping is how we deal with difficult life situations in a more reactive way. So you are stressed at work and then you try to deal with that. Now, crafting goes one step further. It's a proactive behavior, and you reflect really what is important to me in my working life. What do I want to achieve? Which needs I want to have met in my working life? And then I reflect my working life and shape it proactively in a way that it's better serving my needs. And I think that's a real powerful way of looking at life. And as I wrote here, I mean, sense of coherence is great because it gives us an overarching look at life. And crafting is like complementary because it also helps us to shape our life, not only to look at our life, but also to shape our life. And there's really strong evidence, which I cannot share in detail now, that it's highly effective for really improving quality of working life and also work-related health outcomes when people craft more. And the interesting part is that has been developed now originally for the job domain, where you do job crafting and reflect how you can change your task, how you think about your task, also how to improve relationships, because we saw relationships are so important. So for example, if you feel isolated, you will approach more your colleagues and your supervisor to get feedback and so on, then you get more of these social relationships. Thinking about tasks, I just would like to share to the end this very impressive example of people who work in a hospital as cleaners. So you can go into the patient room and just clean, okay, when you're just a cleaner, or you can think and really think differently about your job. When you clean, you really prevent these nosocomial infections in the hospital of occurring with infections, which are really super dangerous. So really make a profound contribution to the healing by that. And even more important, my poor wife had been in the hospital for an extended time, and I observed that some come in and are social agents. They say, hello, how are you doing? And go engage in some conversation. They do not just clean. They are like social entrepreneurs and approach people. And so the patients thrive and they thrive because they enrich their job. That's exactly job crafting. The same can do for private life and boundary management. So with that, I would like to come to the end. I hope I could show you that this salutogenic orientation is quite powerful. Focusing on resources and positive outcomes is very powerful and well supported by good research. And I hope I also could show you that indeed the salutogenic model is not only an idea, but a very sound model which can be really applied and tested in research very well. Thank you very much for your attention.
Thank you very much for your wonderful talk. Now we'll move on to the next speaker, Dr. Georg Choi. She is an associate professor in the Department of Biomedical Sciences at Seoul National University. She's one of few physical activity epidemiologists in Korea, and she has done many important physical activity research, especially using Korean cohorts. And her presentation today will be on psychosocial stress, physical activity, and social network. Please welcome Dr. Choi.
Thank you for kind introduction. And also thank you for giving this opportunity to present in this Salutogenesis session at the Yonsei Exercise Oncology Symposium. First of all, I apologize using my notes in my presentation because I'm not fluent in English, so I think it's easier to listen and understand. So it has been a little 10 years since I began my research in physical activity epidemiology. While contemplating the themes of who engage in physical activity and what the outcomes are, I was deeply impressed by Professor Justin John's lectures earlier this year on the topic of salutogenesis. So I will now share some unpublished results related to the topic I am exploring these days. Please understand that this content is intended for the general population, not for cancer survivors. So this is my disclosure. I have no COI. This is the outline of my talk. After a brief introduction to the factors of physical activity and the study design of the HEXA cohort, in the first part, after sub-diving and validating the psychological indicators of PWI as a stress indicator, I will present research findings on the associations between stress or mental health and the exercise. After that, as the research findings on weekend warrior continue to emerge, I will explain the results of an analysis conducted in conjunction with social network. So this is the ecological model or socio-psychological model is a theoretical framework that defines how multiple factors interact to influence behaviors and health. And Dr. Bauer applied this framework to physical activity, defining the following categories: individual, interpersonal, environment, region and policy, and global, and organize the factors accordingly. The individual and interpersonal categories were presented as the primary factor determining physical activity. So focusing on potential factors among those proposed by Dr. Bauman, we have analyzed factors influencing the initiation, starting, and maintenance, keep going of physical activity through the path analysis, using a health examining code of over 170,000 individuals. I will explain later. Ultimately, we were able to generate a hypothetical structural model encompassing social factors, psychological, behavior, biological, and demographic factors. At this point, Depression was found to influence both initiation and maintenance of leisure time physical activity, while social support decreased the initiation, and the high stress increased the initiation, and the high stress decreased the maintenance of leisure time physical activity. Following this research finding, we conducted subsequent studies on the social psychological factors and exercise, which I will discuss today. The results of this study were conducted in this health examining code, HEXA, we call it in HEXA. The HEXA code is a large-scale code representing Koreans, which began in 2004 and has collected over 1,300 items with samples. I'm sorry, not translated in English. After collecting baseline data from 170,000 individuals, we conducted repeated measures on over 60,000 people and subsequently performed 2 follow-up surveys remotely. The information I will present today is based on the baseline and the first repeated data. So the first part, Dr. Jeong Min-no, my postdoc, who specialized in research methodology in psychiatry, conducted the first topic, bidirectional associations between mental health and physical activity. So the physical activity and psychological factors show the bidirectional relationship as demonstrated in several meta-analyses. Higher physical activity levels are associated with reduced depression, while higher psychological stress levels are associated with lower physical activity levels. However, there is a few reports to assess both of them simultaneously. We focused on more common mental health conditions such as stress rather than clinically diagnosed depression. The Psychological Wellbeing Index, short form PWI-SF, was used as a tool to measure psychological stress in the HEXA data. Developed and proposed by Professor Sejin Chang in Yonsei University, while originally creating work-related stress items, it is a tool for assessing stress in healthy individuals. We first examined the validity of dividing the PWI items into psychological subconstructs. We evaluated validity in 3 main stages. First, qualitative, second, quantitative, and then relevance to physical activity as a behavior in the model. First, the 80 items of the PWI were divided into 4 psychological categories. They are general states as the thematic coding, like self-efficacy, stress or anxiety, perceived health, perceived resources, and life satisfaction. Then we classified them were performed using their kappa value between the items and expiratory factor analysis. Then, by examining the relationship between the original PWI value and its subconstructs with physical activity stage, initiation or maintenance of LTPA, we ultimately, the PWI-SF value was categorized into 3 items: self-efficacy, perceived health, and resilience to stress and anxiety. Then we examined the bidirectional longitudinal associations between psychological factors and physical activity in the HEXA code among around 60,000 participants. This is the result. A higher baseline PWI value, the original one, was associated with significant lower follow-up exercise time, and the opposite direction showed similar strength and consistency. When analyzing by PWI subconstruct, we found that baseline exercise showed a stronger correlation with repeated measure, especially self-efficacy values, than with overall PWI. So in summary, 3 psychological subconstructs within PWI-SF were developed and validated: self-efficacy, perceived health, and resilience to stress and anxiety. We showed the bidirectional PWI exercise relationships. Higher psychological distress predicted low subsequent exercise, and also vice versa. The 3 psychological subconstructs showed bidirectional associations with exercise of varying strength with self-efficacy than other ones, like resilience to stress, suggesting that psychological domains differ in how closely they related to physical activity. As a limitation, the information was collected by self-reported. So further studies may adopt it like objective measures of physical activity. Also, construct deviations. The PWI subconstructs were validated within the same code, so external validation is needed. The second part, we focused on the physical activity patterns related to social network by Hyojin Kim, my PhD candidate. As you know, these are the physical activity guidelines established by the WHO. They set our weekly time requirement. And we are interested in how we feel that time in exercise patterns. The term weekend warrior was defined by Dr. Aimin Lee of Harvard. Exercise patterns that generate sufficient energy to satisfy current physical activity recommendations of 1 or 2 sessions per week, addressing a commonly cited barriers to exercise, like lack of time, compressing exercise into fewer days. In studies reporting on weekend warrior, the definition of weekend warrior based on questionnaires as it follows, like total time and how frequent, like that. And recent studies have also evaluated weekend warrior using accelerometers. Studies report that weekend warrior shows no difference in health benefits compared to the regular active groups, like risk of death, risk of CVDs, and cognitive function as well. So what makes it no different from regular exercise? Pondering this question led me to wonder how about the people behind weekend warrior, and it turned back in my interest, like after the Dr. Stin's lecture, in social networks. A social network is a web of social relationships that surrounds an individual. In turn, facilitate engagement in social activities and access to social support. The characteristics of a social network can include network size and the frequency of contact between network members. In our research objective here, so we would like to examine the associations between social network characteristics and physical activity patterns among Korean middle-aged adults. So we would like to determine whether family and non-family social ties show different relationship with the physical activity patterns. The study was conducted on 110,000 hexa subjects at baseline as a cross-sectional study. In hexa, we categorized exercise patterns by total time and the frequency. So we have 3 groups: inactive, weekend warrior, and regularly active groups. And the weekend warrior and regularly active groups met the WHO recommendation. For the social network, were examined based on types of the relationship and their contact frequency. This is the baseline characteristics. Among hexa participants aged between 40 to 89, the inactive group constitute of 60%, and while weekend warrior accounted for approximately around 5%. Weekend warrior participants were relatively younger, had higher education level, and consumed higher levels of alcohol. Social network size and physical activity pattern, the results. Compared to inactive group, individuals with more non-family friends engaged in more exercise. Notably, weekend warrior is more influenced by the number of friends than by regular exercise group. The number of family members showed no significant association. Then social network contact frequency and physical activity pattern. To examine the qualitative aspects of relationships, we compare the contact frequency. As expected, both within family and non-family relationships, higher contact frequency was associated with a great tendency to exercise compared to the inactive group. When comparing the two components of a social network combined, high contact individuals engaged in regular exercise, while low contact with large network sizes became weekend warriors. In summary, physical activity participation patterns are very depending on individual characteristics. And it was demonstrated that weekend warrior participants tend to socialize more with people outside their family. Furthermore, as expected, social networks categorized by frequent interactions and perceived health quality, high quality positively influence exercise participation. This study has limitation that employs a cross-sectional design using only baseline data and involves measurement error due to the use of questionnaire. In conclusion, physical activity is shaped by the mind and sustained by relationships. Exercise more constantly improves later psychological well-being than psychological stress predicted later exercise. Non-family social ties play the key role in maintaining physical activity, and greater and more frequent social connections, especially beyond the immediate family, were associated with more active lifestyles. This is me. I used to play tennis. My swing was never technically correct, but I enjoyed smashing the ball. Now, I no longer play tennis on weekends. Then instead, I run around the neighborhood with my kid. How can we adapt the way we move so that activity remains meaningful, possible, and socially supported? Physical activity is not a fixed habit. It is a lifelong negotiation between who we are with, and how we live. I would like to thank my colleagues and also the participants of COGES. Thank you for your time.
Thank you very much for your great talk. Now I would like to introduce our last speaker, Dr. Jeong-eun Lee. Jeong-eun Lee is a professor in the Department of Food and Nutrition at Seoul National University. She is one of our world-leading nutritional epidemiologists, and she has done numerous projects, including the study that focus on cancer patients. Today, she will present on the diet and salutogenesis in breast cancer care. Please welcome Dr. Lee.
Thank you very much for introducing me, Dr. Lee, and thanks again for giving me an opportunity to present my research. I'd like to thank Justin Jung and Jeong-eun Lee, my colleague. And I'm a nutritional epidemiologist. So I'm going to talk about the diet and salutogenesis in breast cancer care. Actually, I studied quality of life and some inflammatory markers, which may be very related to salutogenic factors, actually. So, for example, fatigue and also quality of life and some distress. So I'm going to present these results of my study. I have no conflict of interest to declare. And as you know, breast cancer incidence varies across countries. So, and also we have a very dramatic increase of the breast cancer incidence in Korea and also other Asia countries. That tells us that environmental factors contribute a lot to breast cancer incidence. And that really makes investigators to begin investigating the factors, environmental factors, including diet, are associated with the breast cancer incidence. And also, survival rate is pretty high. In Korea, surprisingly, we have a more than 90% of 5-year survival rate. And also, in developed countries, also they have more than 80% or higher 5-year survival rate. About the age group, in Korea, we relatively have a younger age of diagnosis, but now it's shifting to the more older age, but still young compared to the Western population. And we don't know exactly why, but that really tells us that salutogenic factors in these patients are really important. So let me just talk about the breast cancer prevention study. For some reason, we didn't find actually the strong association between diet and breast cancer incidence. So WCRF, I mean, a lot of people, just nutrition epidemiologists, studied the association in the cohort study setting and also intervention study setting, but last like 30 years. But actually, we didn't find actually the association for diet. But interestingly, this is height, and height is a strong convincing risk factor for breast cancer incidence. So they are thinking about maybe diet in adolescent and early adulthood. That might be related to breast cancer incidence, but we don't have a many cohort study, of course, because most of existing cohort assess diet during the middle-aged woman. That's why we didn't see much association. But now they are moving to the they hypothesize that actually the diet in adolescent, well-nourished population and well-nourishment, and also some other like animal product foods, and in the adolescent might be important factor than the middle-aged woman diet, female diet. So the investigators try to search. These are really, really true. So there are some publications in adolescent diet and early adulthood diet are associated with breast cancer incidence. And also we have birth cohorts in Denmark and Norway, and we are also really waiting for their result, but they don't have many cases yet. But they follow up these young women, and hopefully we can find a more clearer picture of this diet and breast cancer. We do have a study in Korea. So Hexa, Georg just presented, published a few papers. So multigrain rice actually decreased breast cancer incidence. And also, this is from the National Cancer Center study, in grilled meat increased the breast cancer incidence. And again, recently they also found the processed meat increased the breast cancer, which is totally different from the Western population, because possibly we have a younger population, but we don't know exactly why. But we need definitely more studies to figure out why we have this association for processed meat and grilled meat and multigrain rice. So now let's move to the breast cancer survivor study. So recently, WCRF, World Cancer Research Fund, just published their findings. World Cancer Research Fund, they collected all the evidences and then summarize mainly using the meta-analysis technique, but they systematically reviewed all the existing articles, previous studies, and suggested some recommendations. But they found that still we need more evidences. Still we need more evidences for breast cancer survivors. But it is very clear that energy balance after breast cancer diagnosis is associated with breast cancer prognosis. So BMI and maintaining the healthy weight is the key factor to halt breast cancer prognosis. And how about the diet after breast cancer diagnosis? Even though WCRF said, well, we need more evidences, we need more studies, but there are some hints that healthy diet pattern is associated with a lower risk of the breast mortality, but interestingly, it's associated with the non-breast cancer specific mortality. So in the United States, for example, around 50% died from breast cancer, but other remaining 50% died from the other causes. For example, cardiovascular disease. Cardiovascular disease is the #1 death cause in the United States. So because their survival rate is pretty high, and so they don't die from the breast cancer, they die from other causes like cardiovascular disease and COPD or other also disease. So still, this result is very meaningful because to improve their quality of life, also their survivors. So even though this is all from the Western population, but that there is some suggestion that a healthy diet pattern actually improves the non-breast cancer specific mortality. So from these previous studies, the key findings are as follows. Epidemiologic studies did not support the hypothesis that diet during the middle adulthood influences the development of breast cancer, but diet in adolescent, diet in young women might be important so our daughters are actually, daughters' health are very important for breast cancer incidence. And energy balance still, we think it's a very convincing factor associated with breast cancer risk and prognosis. Even though premenopause or postmenopause, their directions are different, but BMI and weight change is very important. And diet factors may be attributed to the risks from death, but from breast cancer specific or non-breast cancer specific, we need more studies, but still very interesting to investigate it. Especially in Asian women, very underrepresented in the previous studies. So definitely we need to work hard. We all Asian researchers, we have to work hard, and also we need a very close collaboration with other investigators in other countries. For survivor study, we have very limited, in Korea we have very limited studies. The National Cancer Center study published isoflavone was inversely associated with HER2 breast cancer recurrence, but they have only 25 recurrence, very small study, but still meaningful. And how about the quality of life? And also only a few studies investigated quality of life and diet among the breast cancer survivors. For example, the Italian study, 309 Italian women. It's a cross-sectional study. They found actually Mediterranean diet was associated with improved health-related quality of life. And Chinese study, also they found the vegetable and fruit-rich diet pattern is associated with the global health status and overall quality of life. But we still need a study regarding the association of diet with sleep quality, quality of life, and cognitive function, distress, and other also salutogenic factors. So let me also introduce my study. We recruited more than 1,400 Korean female breast cancer survivors beginning in 2012. with a mean age of 52 years, is pretty young compared to Western population, and with a diagnosis with stage 1 to 3, because we wanted to look at some usual lifestyle. So they can come back to their home and come back to work, and they just live their just usual life. So we included those people to see their just usual life. They have kids, and they have family, and they also work at their working place. So we assessed their diet. This is usual diet and dietary habits, and then also other factors. So we aim to examine the diet and lifestyle characteristics among Korean breast cancer survivors and dietary factors in relation to breast cancer prognosis. Especially, you might be interested in our own diet pattern, like high carbohydrate intake, and also high GI diet, and also the soy products. So we definitely want to take a look at these dietary factors too. And we also want to look at the physical activity and quality of life and sleep quality and fatigue in relation to breast cancer prognosis. And we also take a look at the interaction with the tumor characteristics and also therapy, anti-hormone therapy, and in relation to breast cancer. We are still recruiting more patients. This year, next year, we'll recruit more patients actually. So still ongoing. So we assessed all the lifestyle factors, and education, smoking, alcohol, marital parity, breastfeeding history, family history, and we also examined the quality of life and depression, and we added actually fatigue recently because we also interested in some more quality of life salutogenic factors. So we added more also the sleep disorder part. So sleep quality, insomnia, sleep pattern, and drowsiness. And we're going to also check all these clinical markers, clinical factors from the medical records. So we have ER and PR status, HER2, and also anti-hormone therapy, tamoxifen therapy. All these information are available. And we also measure the biomarkers, even though it's after diagnosis, but after coming back their routine life. So we also measure those biomarkers, and we still have some blood samples in our storage. So hopefully we can measure oxytocin later if there is a certain variation across across the individuals. So let me introduce the study findings. We published more than 20 articles, but most of the cross-sectional studies. So we're still waiting for the hard outcome, but there are a very small number of hard outcomes, like recurrence or METs or secondary cancer or death. We have very small numbers. So we published just one, but because there's only small number of hard outcomes, so we did a meta-analysis, including our study. So certain time, we hope we can get some recurrence and death and MET status. And we found, this is very early publication, we found actually the breast cancer survivors are very interested in diet, and so they tended to have a healthier diet pattern than the general population. When we just communicated with the patients, they're really into this. I mean, they're really interested in diet, and they ask the questions, and we also communicate through this messaging and Kakao, and they send their diet and before eating, after eating with very good, beautiful dishes. And so we really appreciate their contributions. So we all measured this very detailed information on diet. We developed the food frequency questionnaire, and then we validated and we published. But we don't use it anymore because we asked, do you prefer diet records than to FFQ Day? Most of them actually prefer diet records. I like diet records because they think this is really not easy to answer, even though we validated. So I administer the 3-day diet records, but we have a cell phone and we text each other, and we also ask them, could you show what you eat and just give us some photos of yours. So we easily can figure out what they ate. So these days I use 3-day diet records than FFQ. Supplementary use, breast cancer survivors, breast cancer has highest dietary supplementary use compared to other cancer sites. And in our study, also, we found that more than 60% breast cancer survivors use supplements, and women with a higher education levels or longer survival time tend to use the supplements. And number one, multivitamins and minerals, and in Korea, second top, vitamin C and omega-3. That's very prevalent in Korea. And calcium and ginseng. Yeah, you will not be very surprised. Yeah, ginseng is very popular here. So they also want to eat the ginseng to hopefully improve their fatigue and quality of life. I don't know whether this is really true. And we also take a look at the quality of life, and we measure also physical activity, but simple version. So physical activity, engagement in physical activity is associated with the lower scores of fatigue and pain among breast cancer survivors. We also take a look at the guidelines, American Cancer Society guidelines, also associated with the increasing scores of physical component summary, and especially this is more pronounced among women, among survivors with stage 2 and 3 cancer. In our cohort, actually around 50% are stage 1, because very early detection in Korea and a lot of screening. So in our population, around 50% is stage 1, and stage 2, 3 around the rest of the 50%. So we divide into stage 1 and stage 2 and 3, because the small number of population. How about the inflammatory markers? We measured the CLP, IL interleukin series, and TNF-alpha, and we found actually these BMI, of course, as you expected, BMI and weight gain are associated with unfavorable levels of inflammatory markers. And we also take a look at the guidelines, and ACS scores are inversely associated with the CLP levels. This is cross-sectional again. And then, but positively associated with adiponectin levels we published. And how about the isoflavone? We kind of created all the isoflavone database. We created a database, and we calculated isoflavone intake among participants and found that actually isoflavone and soy product intake are inversely associated with the CLP levels. And we also took a look at the specific types of fat, saturated fat, monounsaturated fat, and polyunsaturated fat, and we didn't find a sat fat association. In Korea, for some reason, we don't see many study. We don't saturated fats in many studies. We don't see much association, but we will see because saturated fat intake is increasing. So I think it's because much lower than the maybe Western population. We don't see them much, but because the saturated fat intake is now increasing, so then we could be able to see some association. We will see, but in our study, we didn't see the association either. But increasing MUFA, increasing PUFA are associated with CRP, HSCRP, but lower levels of CRP, but higher levels of adiponectin. So in summary, although overall there is a limited evidence regarding the diet and breast cancer survivor, but its evidences have been accumulating. And we found that actually the breast cancer survivors had a healthier diet pattern compared to general female population. And possibly there is a potential link between dietary pattern and quality of life. And also we are interested in intermediate markers such as inflammatory markers. And we found there's some associations. But we definitely with the further longitudinal prospective intervention study to elucidate the role of diet in breast cancer prognosis and salutogenesis, especially in Asian women. So again, we also welcome the further collaborations, and we do have Asian data. So if you're interested in taking a look at some Asian data, then please contact me. And also some Americans, I think also they are interested in Asian population, because there are a lot of Asian population growing up in United States too. So whenever I presented our results, actually quite a few, people just approached us and then and give me some name cards, and I really like to contact you and want to see the also data set. So I'm pretty open. So we really welcome your further collaboration. So I'd like to thank the funding agencies, and I have so many investigators, my colleagues from the many hospitals. They really helped us a lot. So Yonsei University, for example, Seho Park and Chunjeong, they also helped me to do this research too. And also I have a lot of mentees and postdoc and students. They really work hard to make this possible. Thank you very much.
Thank you very much for your talk. We will now have a Q&A and discussion session.
그럴 수도 있을 것 같아요. 네. 지금 이미 시간이 좀 지났죠.
지나고 30분까지.
Okay, so we'll get questions from the floor. If you have any questions, please come to the mic and ask any questions.
Thank you so much for all three excellent presentation. I think I'm really getting, the health is not determined by one factor. It's a multifactorial. You talk about, work, environment, and work like load and demand, and resources. I think really give me insight how I should work with my graduate students. And sometimes as a manager or as a professor, I need also help from other resources. And also I learn about nutrition, the importance of nutrition, and then within the physical activity, the environment is so important. But my question about nutrition, recently in my class we reviewed, Women's Health Initiative study, and then also WELL study, and then initially there's no association with nutrition, and also and with the mortality and recurrence. Of course later, and then they found some relationship, and that was with the body weight. So now actually the Jennifer Ligabel is doing a BWELL study, large randomized controlled trial, but within those cohort, physical activity, again, strong association. So that's why, ASCO released a guideline, regarding nutrition. There's not enough evidence, but then physical activity, there was a sufficient evidence, and they recommend, a healthcare professional to suggest and recommend exercise. But my question is about sleep, because recently, as I review more and more paper, sleep is so important for our immune function and also the cancer risk and recurrence. But then when we intervene cancer patient with exercise, many of them, they come and say, like, I had the best sleep ever. And sleep quality has improved since I started exercise program. But I heard not much about, I started this diet and then I suddenly sleep better. So maybe, physical activity, the benefit of physical activity, of course, has a direct effect on the, heart outcome, cancer recurrence and mortality. Maybe some of them is mediated through sleep. And the same question applies to both you and you. And then what is your thought on that?
Thank you very much for your question. That's a very good point. So we also eager to desire, we have a desire for finding also the sleep quality and breast cancer prognosis. But because I also was involved in a lot of cohort studies, like pooling project and pooled analysis of cohort study, I think they did not examine the sleep very, very much, as much as like other factors like smoking and alcohol. This is very old factors. But these days, people are more and more interested in chronology and chronobiology and sleep and light exposure and timing of the eating. And so timing and also sleep and light exposure are very important factors, but we don't have many data. So definitely we need to examine this sleep and physical activity and diet all together, and we can take a look at also mediation analysis and whether this is independently associated with the quality of life and breast. It is known that already in general population, also possibly in some cancer patients, and sleep is important for quality of life. But in terms of the prognosis, we definitely need more studies. But that's very, I think, important point. That's why I actually added a more sleep quality in our study, but still a small number of people. But this year, next year, hopefully we can recruit more than 500 people. But we are going to add this whole set of the sleep quality. So hopefully we can find some meaningful. And then if we have a more and more sample size, we can do the mediation study and mediation analysis, whether physical activity really get through the sleep and then associated with the other factors. So that's actually what we have to do in the future.
I would like to add some comments of diet and design. Actually, you mentioned there's very little associations between diet and the outcomes in cohort. And actually, there is very, very difficult to collect diet information in cohort design because in cohort, we should wait for some times to have some outcomes. And also we need to collect the data at baseline, like 10 or 20 years ago. But diet pattern is really, really different as time goes by. For example, in our Hexa code, we have questionnaires and what kind of food do you eat like that? Vegetable, green, or yellow like that. But these days we eat sandwiches and how to check that kind of information. So yeah, maybe some very very interested in food. Some people are very interested in food. They check all of them, but it's very difficult. So I think it's the difficulty in the design, also in diet collection. So maybe Jung-eun are interested in these days like the app-based collection, like Kakao.
Yeah, so diet assessment has been daunting, challenging the last 40 years, and so a lot of people actually worked hard to assess diet. Still a lot of measurement error. That's why the Harvard team did a repeated measurement every 4 years to reduce the measurement error. And also we now try to adopt the IT-assisted measurement. So, but in terms of, we always say that ranking is important. So if there are some those who eat a lot, then anyway they contribute a disease. So I would just say this no association is totally due to the measurement error. That's actually no. We think hypothesis is not the correct. So still middle-aged woman diet may not be associated with breast cancer, but because they see the results, they see the results in adulthood, and then your daughter's diet are important for breast cancer. And they see there's the same measurement error, and there are a lot of measurement error in adolescent, even more measurement error in adolescent diets. But they still see some hints, some suggestions. So we are really waiting for whether this hypothesis is correct. So I would say no association may totally because of measurement error. That might not be true. So still, measurement error is huge in diet assessment, but this young adult hypothesis could be possible, and because we see the height is a strong risk factor for breast cancer incidence, and we will see how the other results are coming. Yeah.
Yeah, first, coming back to your question regarding sleep, I mean, in our field of mental health related to work also, I mean, sleep is the most important resource for recovery, as we would call it. Nowadays, we all have a lot of, let's say, stress and strain because we need to pay attention to so much information and much is happening online. So our attention is really so much overstrained that we really need to deeply recover from that. And so sleep is really important for that. Related to physical activity, I mean, there's also research also done from a salutogenic point of view. Where can you recover best mentally now? And again, there it makes a big difference if you exercise in an urban environment or if you have some exposure to some natural environment. That's much better for your mental recovery, not talking about the physical effect, but really the mental effect. And I think this is something I would really suggest for our whole research fields, you know, that we need to think a little bit more multidimensional when we think about health and the health effects as this case of recovery. So for nutritional research, I mean, I also was supervising a PhD recently who also was assessing the nutrition intake in Switzerland in different fields. And I was always surprised that somehow this field is not paying a lot of attention, I think, about how you really eat your food. I mean, certainly food is important, the composition, the nutritions, but it's a social event, you know. Do you eat on your own or do you eat with others, which is a completely different experience, and certainly I would say probably even more important what exactly you eat, how you eat it, and also do you take time, do you eat it in a mindful way, or do you just get your calories in to go on with your job and maybe don't even pay attention. Many do a desk lunch, which sounds very efficient but very poor from a health point of view. So I was wondering, thinking about your two presentations, because I think you made this very interesting point that you also assessed the social context or predictors of exercise. So is this something also in the nutrition field, but you also would look more into this field of how nutrition is really happening in a social context and even also in this mental context, how much attention you pay to nutrition?
So you gives us more homework. Yes. So social networking is we think pretty important. So in the National Nutrition Data Survey, they ask, do you eat alone or you eat with a family? So we have those like monitoring setting. We keep asking them because there are more and more people are just eating alone. So and then and also do you eat in? We also in the national monitoring data we can check whether they eat in the working place or they work in family or in home, And but when we do this cohort study, I would like confess that we don't include this many social networking things in our questionnaire. We always get criticized. Please reduce your questionnaire. Please reduce. And I cannot reduce because we have to calculate the energy intake. But so we kind of but that really makes me insist more that we needed this variables in the survey, in the cohort study. Yeah.
I have one quick question to Dr. Bauer. Thank you for your insightful lecture yesterday and also today. As you can see, there are many students attending this symposium, and I think your lecture today is very important for all of us. And I was wondering if you could give any advice to our students to increase salutogenesis at work and also research.
Well, I mean, yesterday I showed that it's really, I mean, also Aaron Antonovsky, the author of Salutogenesis, was very much insisting that it's always about the right question. So I think also when we work with PhDs in our own environment, back at my own university, we always encourage to certainly ask the pathogenic question, what is leading to disease outcomes and why is nutrition, some nutritional ingredients maybe not good for your health and cancer outcomes, but then always add the salutogenic question, what beyond with risk factors could also be positive, promoting, supporting factors which would help for a better outcome. So always also look at this bright side. That would be the one thing I would suggest. And as I also just said in my previous comment, always have with all three dimensions of health in mind simultaneously. So not only focusing again, for example, with breast cancer, only breast cancer as a certainly physical happening, but really, as also the colleague suggested, with physical activity, think about the social dimension, what are the social factors, and also particularly the mental factors. So all three dimensions, always from both a pathogenic and salutogenic perspective. That would be my suggestion.
And I have also questions for Dr. Bauer. So your model integration of job demands and resource into the salutogenesis is very clear and actionable structure, especially in the healthcare setting. It is very relevant to hospital settings in which many nurses and doctors are experiencing everyday stress from their patients and caregivers or other co-workers. Have you ever implemented your key model into actual hospital or actual organization?
Yeah, I mean, we did work quite a lot also with hospitals and did exactly this kind of workshops which I showed with hospital staff, and also often we aimed for really doing this in an interprofessional way. So we always try to bring together both doctors and nurses because they work so closely together, and often conflicts and stresses are emerging out of a lack of good collaboration and understanding of each other. So we did quite some interventions also in the hospital setting, also bridging this or facilitating this interprofessional collaboration. Also certainly found linking it also with the patient perspective. I mean, in Switzerland we had a big movement towards lean management in healthcare. Probably about lean management, that you need to or try to become more effective, more efficient, and lean down your processes. And that has been done in hospitals. Unfortunately, mostly it means that the patient outcomes improved. Work was done more efficiently for the patient, but then the staff suffered because their work even was more intensified through this lean management process. And there we developed an approach, a dual approach, where we said you need to aim simultaneously in improving patient outcomes and staff outcomes. So we really did this kind of lean management process, always thinking about how could a change process at the hospital, how you deliver healthcare, be improved in a way that the patient would more benefit, but again also the staff would find more fulfillment and really can live out their identity as a nurse or a doctor.
Is there any barriers to implement your model into the hospital? Because In our hospital, university affiliated hospital is a non-profit organization. That's the big problem implementing this of model and also exercise oncology in the hospital setting. So is there any barrier you should overcome?
Barrier, because when you look into statements, for example, from the World Physician Association, there it says one also needs to take care of the health of the physician in order to assure good patient outcomes. So I think the biggest barrier is that normally patient health and outcomes are valued much higher compared to the staff health and well-being. So it's subordinate and it's only a mean towards the true end of patient well-being. And I think that needs to be changed. It needs to be brought on an equal level, that both patient outcomes and employee outcome and experience are valued equally. So it's a value decision, but you can influence that by good evidence. And we are currently working on a project where we exactly want to demonstrate that a good co-production of health by the patient and the staff will benefit both sides equally.
There's no other questions. We'll now end the session. Please give a big round of applause to our speakers.
Thank you for joining us today. This concludes Symposium Day 2, the fourth Yonsei Exercise Oncology and Salutogenesis Symposium. We sincerely appreciate your participation, and on your way out, can you please return your name tag? We wish you a safe trip, and thank you.
Thank you. 우리 밖에 있는 사람들 좀 들어오라고 할래? So thank you so much for coming all the way from Netherlands, Switzerland, Canada, and Japan, and Australia. Wow, I mean New Zealand. Yeah, New Zealand. Sorry. Yeah. So I think, and also many people from many different regions of Korea. Seoul National, Suncheon University, NCC. Like I cannot name all. But thank you so much for coming to Yonsei for last 2 days of intense presentation and discussion and debate. So really, but then I like to thank my student. Maybe start with Donghyuk. He's the stand up, yeah. And Banaba, pictures, yeah, please, yeah. He made this, YouTube live possible, so many people from all over the world was watching this symposium. Yesterday, I see how many people watched our first day. Over 500 views. So a lot of people already watched this symposium. I'm sure they learned from that. But it's not only Donghyuk. Everyone else from my lab, please stand up. Okay. Yeah. Yes. Thank you. So, like moving this chair. Actually, this is not light. And yesterday, one of them just lift, by himself, and then as today he got the blame. So he's doing it with other people. But not only the moving chairs, but then they help organizing everything. Like Unchan, where's Unchan? Yeah, he yeah. 왜 혼자 박수 쳐? Yeah? He arranged all the transportation, hotels, and send emails, getting the presentation, and sending it to chairs. It was a lot of work from many other people. It's not only them, but also from our graduate program. They stand outside in the cold weather, doing the registration, ordering coffee, make sure everything's ready. But this would have not been possible if there was no help from our student. I really appreciate it. And then also our faculty member, 우리 윤 교수님 나가셨나요? 윤 교수님. 유영진 교수님 and 변진수, Professor Byun, and then Dong Lee, like all the, 허지무 교수님. So like, without all the support and the help with our faculty member, this would have not been possible. And then every time, like this is our fourth conference, every time we do it, our students come up with a new idea. How about the LED screen? How about this like banners? Like every year they come up with new ideas, and then they burden themselves with more work. So at first we did the Zoom live with just our notebook computer, and then this time when we were doing with the Kerry Courneya, we needed 4 computers with the live Zoom. So every time we do it, it's evolving. But then what we are seeing is not about the organization and how technologically we have better system. That's not the main point. I think every year we are progressing with the knowledge, and that is directly benefiting our cancer survivors. And maybe hopefully this year we will see more impact to the society, and then maybe more hospitals will realize, more organizations will come up with a cancer program for our patients so our patients can benefit. I think we're all working together as a team, and then maybe next year at 5th exercise oncology symposium, maybe I don't know how will happen, but then it doesn't mean bigger doesn't mean it's better, but maybe we'll come back here and then do a smaller scale. It doesn't matter, but then as long as we progress and make impact. So thank you so much for participating, all the participants, and also our speakers, Georg and also Jung-eun. I mean, they take risk because they didn't know about sallutogenesis, and they had to study. And coming here and making the presentation. So thank you for taking risk, and then showing some data, and then thank you. I really appreciate it. So with that, it's time to take a picture. So this time we're not going to ask everybody to come out, but we will do a selfie. Is that okay? So if you are on the side, please move to the middle. 교수님 이쪽으로 가운데. 엄구 안 나와. 민치 안 나와. 가운데 앉는 거 좋아. 가운데 앉아도 돼. 일단 하나 찍고요. And I'll do this. Okay. And maybe one of the person come out. 아니야, 우리 박경 박사 운동약을 그리고 운동약을 이긴다. 윈. 준비됐어? 마지막에 마지막에
드리겠습니다. 하겠습니다. 운동약을